मेरे को बैकएंड से तो रेडी करना पड़ेगा ना.
हाँ, बैकएंड तुम अभी रेडी कर लो.
But we will go live. We'll start speaking at around 5:59 to 6.
Yes, 5:59.
Yes.
Yeah.
कौशल क्या है उसके अंदर?
चाय है सर, चाय.
जो कह तो मानना पड़ेगा. डॉक्टर कोशी गिविंग अ बिग स्माइल.
सर अभी 6 ही बजे है ना, इसलिए.
6 बजे से क्या मतलब होता है? सुबह के 6 बजे भी लोग पीना शुरू कर देते हैं. Dr. Koshi, don't you think that webinars are more of a stress to us than live meetings?
Because we are not used to it.
No, just see, everybody is so tense. Time ho raha hai.
Yeah.
Yesterday I was telling somebody, I think it's time everyone should invest in a good internet connection rather than anything else.
So the problem is the internet providers are not very good.
The connection is what is worrying everybody.
Yes.
Yeah.
Suppose there's a cable defect. What can you do about it then? Let 5G come, then things will be fine.
Yesterday, because one of the, I think, case presentation, you are facing a lot of challenge for the connection.
No, you will have problems right now because I have 2 connections. I remember one of the webinars, both the connections were down. But if you have 5G, then things will be fine because it will be Wi-Fi. I mean, without
Wi-Fi.
It will be 5G just from your phone straight away.
Dr. Kaushal?
I'm here.
Okay, so we are live now, right? So we are still 1 minute we have, so but we are live.
We'll start in a minute.
Dr. Kaushal, we can go ahead now.
Okay. So good evening, everyone. We welcome you once again to this day 3 of our 27th annual scientific meeting of Indian National Society of Study of Liver, Indian National Association for Study of Liver. Sorry for that. We had a wonderful last 2 days of meeting, and now I welcome you once again to a great academic clinical feast this evening. And before we move ahead, I would like to make a short announcement that for the delegates, the e-certificates are available in a downloadable format in the platform in the exhibition area. So those of you who are interested in getting that certificate can go there, click on the link of e-certificate, and that will be downloaded to your computer. So with that, we start the proceedings, and the first agenda of the day is Dr. D.V. Datta Memorial Oration. And for that, I would like to invite the chairpersons. We have Professor Abraham Koshi, who is the Professor and Director, Research and Hepatology at VPS Lakeshore Hospitals, Kochi, Kerala. Welcome, Professor Koshi. And we have Dr. S.P. Mishra, who is the Professor and Head, Department of Gastroenterology at Motilal Nehru Medical College at Allahabad. Welcome, Dr. Mishra, and please take over and start the proceedings.
I would like to introduce Professor D.V. Datta. Professor Datta started the first department of hepatology in India at PGI Chandigarh in 1971. He graduated MBBS in 1958 from BR Medical College, Gwalior, Madhya Pradesh, India. After MD, he did PhD under Professor Dame Sheila Sherlock at Royal Free Hospital, London. Professor Sheila Sherlock, as many of you know, is known as the mother of hepatology fondly. He then worked at Harvard Medical School, Boston, with Professor Kurt J. Isselbacher, before returning to India and joining PGI in 1967. He had 110 publications, including seminal work on hepatic outflow obstruction and drug metabolism. He had a childlike curiosity with an intricate knowledge of experimental methodology. Professor Datta was born in 1934 and passed away at a young age in 1981. I had the good fortune of working with him from 1976 to 1981. I am honored for this opportunity to pay my tribute to him. Thank you.
Today's orator is Dr. Paolo Angeli, and all of us know him very well. To stretch the metaphor, he is a household name in gastroenterology and hepatology. He'll be delivering the D.V. Datta Memorial Oration. He'll be speaking on news in the management of ascites in patients with cirrhosis. Dr. Paolo is a head of internal medicine and hepatology university at the teaching hospital in Padova, Italy. He's also the secretary of the International Club of Ascites, and he's editor-in-chief on the Journal of Hepatology. So over to Paolo now.
Mr. Chairman, dear colleagues, first of all, I want to thank Professor Madame and all the other organizers. I'm very emotional. I'm very, very happy to give this talk in memoriam of Professor Datta. It's probably the greatest honor I received in my professional career, and I will never forget it. So in my talk, I will develop the theme of news in the management of ascites in patients with cirrhosis following this agenda. First, some news in the pathophysiology of decompensation and organ failure in patients with cirrhosis. Then, some news in the evolution and classification of decompensation in patients with cirrhosis. And finally, some news in the treatment of ascites in patients with cirrhosis. And let me move from the first point. For more than 30 years, we went on thinking that the only driver of decompensation in cirrhosis was a progressive increase in portal hypertension with a related progressive derangement in circulatory function, with a related progressive increase in the degree of activation of vasoconstrictor and sodium retaining factors. This is true for sure, but this is only part of the truth. Why? First, because if we look at the most advanced phases of the liver disease, you can see that there is no further progressive increase in the degree of activation of vasoactive and sodium retaining factors. Second, we can modulate the degree of activation of the vasoactive and sodium retaining factor without obtaining any significant clinical outcome. No reduction of the rate of complication of your life, and no improvement of survival on your right. Third, during the last 10 years, we learned that a new syndrome, acute on chronic liver failure, may develop at any stage of the liver disease, but particularly in patients with decompensated cirrhosis. And the ACLF is characterized by an acute onset, the development of organ failures, and a deep negative impact on short-term survival. Now, we know that ACLF may develop even in presence of no activation of the vasoactive and sodium-retaining factors, such as plasma renin concentration, but never in absence of systemic inflammation. So there is an association between systemic inflammation and the development of organ failures. The question is this association random or is it casual? Let me show you. This is a group of cirrhotic patients who develop an acute decompensation. What does it mean? It means that they need to be hospitalized emergently for a severe complication of the liver disease. So AKI, bleeding, grade 3 on 4 hepatic encephalopathy, bacterial infection, sudden increase of ascites, and so and so and so. Well, you can see there are two subgroups according to this odd map of the median value of the most important pro-inflammatory cytokines. The red mean a higher median value of the pro-inflammatory cytokines. And you can see that in the first group, that include patients who did not develop ACLF, the mean level of the pro-inflammatory cytokines is quite lower than in the second group that includes patients who develop organ failure and ACLF. So the association between systemic inflammation and the development of organ failure is not random, it is casual. But let me show you that systemic inflammation, it is not only present in patients with organ failure, it is still present in patients without organ failures. And I will come back on this concept later on. But now let me introduce you another potential driver of the decompensation in patients with cirrhosis, that is oxidative stress. This is the molecule of albumin, and you all know that in position 34, there is a residue of cysteine that is capable to bind ROS. But in doing so, albumin is oxidized, either in a reversible form, non-mercaptoalbumin 1, or in an irreversible form, non-mercaptoalbumin 2. Well, if you look to the sum of these two forms of oxidized albumin, you can see that there is a progressive increase in the level along the course of the liver disease. So another potential driver of decompensation is oxidative stress. And now the problem is how to put together portal hypertension, systemic inflammation, and oxidative stress, of course, in a new paradigm, in a new pathophysiological hypothesis, according to which the main consequence of portal hypertension and liver failure is bacteria translocation. That is the cause of systemic inflammation and oxidative stress. That in turn will induce the macrocirculatory dysfunction and the reduction of the effective circulating volume. There are no other mechanisms by which liver failure and portal hypertension can induce these relevant pathophysiological changes. And then systemic inflammation and oxidative stress, together with the activation of the vasoactive and sodium retaining factor, will cause the onset of ascites. But you know, systemic inflammation and oxidative stress generate a vicious cycle by which there is a further increase in the degree of liver failure, in the degree of portal hypertension, in the rate of bacteria translocation, and so a further increase, a further progressive increase in the level of systemic inflammation and oxidative stress. So at any time during the course of the liver disease, organ failure may develop with or without the intervention of precipitating factors. But let me move now to the evolution and the classification of decompensation of cirrhosis. I mentioned it before, acute decompensation, and I stated that it is the need of emergent hospitalization in a cirrhotic patient for a severe complication. What happened to the cirrhotic patient after the development of acute decompensation in the hospital? Well, they can follow three different trajectories. The first one is the development of ACLF. This occurs in almost 1/3 of patients who develop acute decompensation. And you know that ACLF is associated with a very high mortality rate according to the number of organ failure. As a mean, we can state that the mortality rate of 3 months in patients who develop ACLF is higher than 50%. The second trajectory is unstable decompensated cirrhosis. What does it mean? It means that these patients do not develop ACLF, but they need very frequently emergent readmission during the following 3 months. And in this group, the mortality rate is higher than 20% at 3 months. The third trajectory is stable decompensated cirrhosis. What does it mean? It means that these patients do not develop ACLF, do not require emergent readmission during the first 3 months, and have a mortality rate, not at 3 months, but at 1 year, that is below 10%. What happened before the development of acute decompensation? Well, 1/3 of patients move directly to acute decompensation from the compensated stage of the disease. But 2/3 of patients had already developed ascites. So we should admit that there is another pathway of decompensation that I call non-acute decompensation. And this situation may sometimes recover as a result of some etiological treatment. So, for example, abstinence from alcohol or antiviral agents. But let me focus on these trajectories. Because, you know, ascites is a predictor for the development of ACLF, together with a low mean arterial pressure, an high MEL score, and the presence of anemia. And you know, the probability for cirrhotic patient with ascites to develop ACLF is 14% at 1 year, 29% at 5 years, and 41% at 10 years. But if we speak about acute decompensation, this number should be doubled. Well, I stated that cirrhotic patients with ascites have a high probability to develop ACLF. This is true not only for patients with clinically overt ascites, but even for patients with grade 1 ascites. So for patients whose ascites is detectable only by echo. And this is quite important, you know, and which is the reasons of this? The reason is that even in patients with grade 1 ascites, systemic inflammation is present. Of course, systemic inflammation will further increase in patients with grade 2 or grade 3 ascites. And among these patients, the degree of systemic inflammation will progressively increase, moving from responsive ascites to recurrent ascites to refractory ascites. So let me summarize this view. We think that in the compensated stage of the liver disease, the main point is the progressive increase in portal pressure. But in the decompensated stage of the liver disease, the main point is the progressive increase in systemic inflammation. And let me go on with the last point, new developments in the treatment of ascites in patients with cirrhosis. Let me move from grade 1 ascites. 30 years ago, we stated that these patients do not require any type of treatment, no dietary sodium restriction, no diuretics, but we didn't know anything about the natural history of grade 1 ascites. Now we have some new about the natural history of this patient. We know, for example, that they have not a higher risk to develop an overt ascites as compared to patients without any evidence of ascites. So the statement of no treatment is right. But we know that this patient has a lower probability to survive as compared to patient without ascites. So patient with grade 1 ascites should be followed more closely. What about patient with grade 2 ascites? The standard of care is dietary sodium restriction and diuretics. But we can do something better. And I will present you again the result of the ANSWER study, a randomized controlled clinical trial we performed in Italy. So we compare the standard medical treatment of grade 2 ascites in patient on diuretic treatment. So we are speaking about responsive ascites versus the standard of care plus long-term use of albumin, 40 grams per week. And we were able to show that the long-term use of albumin was capable to reduce the rate of development of refractory ascites, was capable to reduce the rate of development of SBP, of infection other than SBP, of hepatic encephalopathy and renal impairment, and so was able to improve survival. So the long-term use of albumin is useful in the management of responsive ascites. What about refractory ascites? We can state the same. This is our prospective non-randomized clinical trial, real world, showing that if we compare in patients with true refractory ascites, the standard of care, so therapeutic paracentesis plus diuretics, plus the long-term infusion of albumin, 40 grams per week, we are able to reduce the mortality rate. We are able to reduce the probability to be readmitted to the hospital for any type of complication, ascites, SBP, HRS, hepatic encephalopathy, infection other than SBP, with only one exception, that is variceal bleeding. So the long-term use of albumin is useful also in the management of refractory ascites. We think that in both these scenarios, responsive ascites and refractory ascites, albumin is acting not through the oncotic properties of the molecule, but through the non-oncotic properties of the molecule, particularly the antioxidant action and the anti-inflammatory action. Such proving, I will show you some recent data we have, proving that albumin is capable to go into the leukocyte, is capable to go into the PBMC, the green point, particularly in presence of pumps. So, for example, during a bacterial infection. And within this cell, albumin is capable to reduce the production and the release of the pro-inflammatory cytokines. By this way, albumin is capable to prevent the development of organ failure or even to recover the organ dysfunction. And several years ago, we proved that, for example, in the cardiac tissue, albumin was capable to normalize the production of ROS. And by this way, it was capable to avoid the negative impact of ROS on the beta-1 signaling pathway in the cardiomyocyte. But what is more important, we were able to show in the cardiac tissue that albumin was capable to normalize the expression of TNF alpha and was capable to normalize the expression of inducible nitric oxide synthesis. By this way, albumin is capable to reduce the release of nitric oxide, that is a very negative molecule for the beta-1 signaling pathway in the cardiomyocyte. Albumin is capable to block the release of nitric oxide within this cell, and by this way, it is capable to restore the cardiac contractility in an experimental model of decompensated cirrhosis. This is not possible using another plasma expander. And these data were recently confirmed in patients with decompensated cirrhosis. You can see that albumin is capable to increase the cardiac index. The problem is that we should give a very high dose of albumin, 1.5 grams per kilo body weight, to get this result. Why? Because only giving a high dose of albumin it is possible to reduce in a very significant way, in a very stable way, the degree of systemic inflammation. So in clinical practice, we should almost normalize the plasma level of albumin in our patient. The sooner we get this result, the better, because you can see that if we normalize at 1 month the level of albumin in our patient, there is a clear positive effect on survival. The final point, by exerting an antioxidant action, by exerting an anti-inflammatory action, albumin is subjected to several changes in the molecule with a loss of biological function. I call these changes post-transcriptional changes, and they are very complex. Truncation at the N-terminal of the molecule, truncation at the C-terminal of the molecule, cysteinylation, sulfonylation, glycosylation. In one word, we can see that there is a progressive reduction of the fully biological active or native albumin along the course of the liver disease. And according to a lower level of native albumin, there is an impairment of survival at 1 year in patients with decompensated cirrhosis. So let me summarize what I said. The pathophysiology of decompensation in cirrhotic patients is quite more complex than the simple increase in portal pressure. Systemic inflammation and oxidative stress are two powerful drivers of decompensation. Grade 1 ascites does not need any treatment, but patients with grade 1 ascites should be closely followed because they have a high risk of mortality. The long-term use of albumin is useful in the treatment of both patients with responsive ascites and patients with refractory ascites because it is associated with an improvement of survival and of the quality of life. Usually we think that albumin is a plasma expander, but probably it is one of the most powerful antioxidant and anti-inflammatory agent we have for the clinical practice. The problem is that we should use high doses of albumin to get the result. And finally, that in doing the anti-inflammatory action and the antioxidant action, albumin will lose biological function. And the loss of biological function of albumin is associated with an impairment of survival in patients with decompensated cirrhosis. I want to thank all my research group for the beautiful results they got in the past and they are continuing to get. And finally, I want to say thanks again for the invitation. I have only one sorrow. I cannot be today among you, but I hope that this will be possible in the next future. Thank you very much.
Thank you, Paolo. That was a masterly oration and wonderful things we have learned today. Congratulations, and I hope you continue the research and we get something more from it. Over to Kaushal.
Thank you so much for chairing this session, Dr. Koshi and Dr. Mishra. And thanks, Dr. Anjali, for a wonderful presentation. And like Dr. Mishra said, I think all of us have learned immensely from this particular oration. And definitely we'll send you the citation certificate by a courier.
Thank you very
Thank you
much.
so much.
It
Thank
was
you.
a great pleasure and a great honor. Thank you. Thank you very much.
Thank you so much, sir. So let's move on to the next session, which is the NASH Symposium. And the educational partners for this are Zydus BioNext. I would like to invite the chairpersons for this session, who are Dr. K. Narayansamy, who's the Director and Professor, Department of Hepatobiliary Sciences, Madras Medical College, Chennai. Dr. Siva Prasad, who's a Senior Consultant Gastroenterologist and Hepatologist in Visakhapatnam. And Dr. Sandeep Thareja, who's a Deputy Commandant and Head of Gastroenterology and Hepatology at Base Hospital, New Delhi. So welcome, chairpersons. Over to you to start the session.
Yeah, thank you, Kaushal. It's a privilege to be chairing such an important session in this INASL meeting. And it's more a privilege to be inviting Dr. Naga Chalasani, who is going to be speaking to us today on the therapeutic advances in NAFLD. He's such a well-known figure. Introducing him is a little redundant, but still I'll have to mention that he is currently the professor of medicine at Indiana University, and he has more than 300 publications in the field, especially the ones that are most frequently cited, as we well know, the standard almost benchmark guidelines. And it is also personally a privilege for me to say that he is closely linked to Visakhapatnam. He has strong connections here. So it is, as far as the topic is concerned, I always like to say that NAFLD is a single most prevalent disease in the world without a treatment, if you look at it that way, the numbers wise. But today, Dr. Naga Chalasani will be talking to us on therapeutic advances in NAFLD and what is it that we can look forward to the near future. Over to Dr. Chalasani.
Can you see my slides?
Yes, sir.
Good morning. What about, is my video okay?
You're all fine, sir. You can go ahead.
Yeah, thank you so much. Good morning,
Go
Good
full
evening.
screen, sir.
Thank
Go
you.
full screen.
We've just lost your video.
What about now?
Now you're back. You can go ahead.
Okay. Hey, good evening, Shiv Prasad. It's such a pleasure to be speaking to your group. I want to mention, I find it a great privilege to be speaking to your group when the chairman is Dr. P.N. Rao. 30 years ago, my first exposure to gastroenterology was under Dr. P.N. Rao when he was gastroenterologist at Nizam's. He probably won't forget, as he's taught hundreds of graduates from India. So it's truly an honor to be speaking to you, Dr. Rao. And Shiv Prasad, you know, you and I have the connection. My hometown is Visakhapatnam, so that's a great privilege as well. And I see Ajay and others who are great friends. So let me get started here. This is an abbreviated version of a talk that I've given for the AASLD debrief. These are my disclosures. And then I want to thank many presenters who have graciously made their slides available to me for including in this presentation. So the AASLD had about 15 therapeutic studies presented either as oral presentations or as posters. There were 6 important studies with histological endpoints, and there were 4 phase 2A studies, which are proof of concept with non-invasive endpoints. Let me touch each of these. So this is perhaps one of more exciting studies to me. This is with lenafibranor. This is from Europe. Senior author is from Belgium. This is lenafibranor is a pan-PPAR agonist. You know, here it is sort of balanced agonism against alpha, delta, and gamma. You may remember the Indian compound saroglitazar is alpha gamma, whereas GenFit compound was alpha delta. So this seems to be a pan-PPAR. And there are some human data to say this can be safely tested in NAFLD. This is a phase 2B study. This is a 24-week study with a 4-week follow-up. 2 doses of lanifibranor were tested, 800 and 1200 milligrams once per day. Inclusion criteria are a bit odd compared to other NASH studies. Typically, the NASH studies use NASH CRN histological criteria. Here they use the SAF, which is Pierre Bedoza criteria from France. And there are 2 data sets here. One is the full analysis data set, which is approximately 250 patients, and per protocol is 194 patients. They had important subgroup analysis for those with diabetes, as well as those who had both only stage 2 and stage 3 fibrosis. By the way, cirrhotics are excluded from this trial. And the primary endpoint is once again a bit odd compared to what we have seen with other registration trials. Here, this is a 2-point improvement in SAF score with no worsening in fibrosis. Number of secondary endpoints, these are traditional endpoints, and there are some exploratory endpoints as well. 247 patients were randomized, little over 80 patients in each of 3 treatment groups. What I want to point out is excellent completion rate, over 90% completed the 24-week treatment and had liver biopsies done. This is exceptional. One point though, this could be because this is a 24-week study. As you will see in some of the other studies I'll be talking to you, as the treatment duration goes longer, there seems to be attrition and the failure or higher dropout rates. So the primary endpoint was met with the 1200 milligrams of lanifibranor. What you see on the left side is full analysis data set. Approximately 50% of active treatment at 1200 milligrams achieved this primary endpoint, whereas only 27% in placebo. This is highly significant. Same results were seen with per protocol, 194 patients. Authors pointed out these results were consistent in diabetics. There was a late breaker poster. And then also when they limited analysis to those just with stage 2 and stage 3 fibrosis. A number of other secondary histological endpoints show the same sort of a result. Resolution of NASH, just with 24 weeks, is about 45%. This is remarkable in my opinion. And improvement in fibrosis is 42% compared to 24% in placebo. And when you combine both of these, this is a high target. About nearly a third achieved just once again within a 24-week treatment. And there are results are similar in both diabetics as well as those with stage 2 and stage 3 fibrosis. This trial is moving forward to a stage 3, but like all PPARs, especially when you have, I think when you have pan-PPAR, you're going to have some other benefits. Here you see some lipid benefits in terms of increase in HDL and lowering of triglycerides, and an improvement in glycemic control. But what you see is some safety concerns. If you see there is a numerically higher treatment emergent adverse events in the 1200 milligram dose, nearly 8.4%. And not so unexpectedly, weight gain was present in about nearly 10% of 1200 milligram dose. I think this was about 2.3 kilograms. And there was weight gain and also transaminases increased. There are about 8 patients in the lanifibranor that had increases in transaminases. These need to be scrutinized. So bottom line, this is exciting efficacy, but we just have to see how this is going to play out in a phase 3 and perhaps in longer term studies. Next is semaglutide study. Phil Newsome has presented this, and also this, I believe, has been published in New England Journal of Medicine not too long ago. You know, semaglutide, glucagon receptor agonist here, has plethora of effects, beyond glycemic control that just sort of make great sense for NAFLD pathobiology. This trial had 3 treatment groups, 0.1, 0.2, and 0.3 milligram sub-Q injection compared to placebo. Classic eligibility criteria: patients must have biopsy-proven NASH. NAS should be 4 or higher. There should be fibrosis, at least overweight, and reasonably controlled A1C. Primary endpoint, though, is back to the traditional primary endpoint: resolution of NASH with no worsening in liver fibrosis, but only limited to patients with stage 2 and stage 3 fibrosis. I'd like to point out they included about a third of their cohort was stage 1 fibrosis, but this was a predetermined primary endpoint group. And they also had a confirmatory secondary endpoint, which is improvement in liver fibrosis with no worsening in steatohepatitis, once again in the same subgroup. So I believe approximately 80 patients were enrolled in each group, giving to about 320 patients. And I think withdrawal from the trial, but the completion rate, though, if you look in total completion, is only 83%. And this is much higher than what we have seen with lanifibranor. Could be a function. We are talking a sub-Q injection daily, as well as a lengthier treatment duration. And this is the primary endpoint. What you see here is I'd like to draw your attention to 0.4 milligram dose. The checkered bar is the stage 2, stage 3 group. 56% had resolution of NASH with no worsening in fibrosis, relative to 20% in placebo. And in other doses also had p-values statistically significant, but the most striking result is with the semaglutide 0.4 milligrams. However, though, is the fibrosis was surprising. Semaglutide group, if you look at it, 40% had improvement in liver fibrosis, but they had a very high placebo rate, nearly 30%. This is a bit inexplicable. And authors really did not have a good explanation to why such high placebo response in this particular study. As one would expect, there are impressive weight loss, body weight loss, as well as A1C improvement. In the highest dose, you're seeing minus 1.28% drop in hemoglobin A1C. That's quite impressive. Lipid profile is favorable, as one would expect in patients with weight loss. And adverse events seem reasonable. Numerically, did not seem terribly higher compared to placebo. Some of the things that you worry in GLP-1 agonists, there is a little bit of a signal with gallbladder-related disorders and some severe hypoglycemia. But I believe this is going into a phase 3 program, at least in North America, probably throughout the world as well. This is certainly an exciting molecule. I think that we may see approved for NASH in the next probably 3 to 5 year time frame, especially if you can sort out the issue with fibrosis. This is a trial our own Arun Sanyal presented, Flight FXR. This is Novartis compound. This is tropifexor. Tropifexor clinical program had multiple phases. Part A and Part B were already presented. These were proof of concept. Here, Part C, week 48 results were presented. Part C is a 48-week study, but the first 12 weeks were where the primary endpoint of hepatic fat concentration was shown to be effective. And here the authors were presenting the histological efficacy and safety. Tropifexor is a non-bile acid agonist of FXR, which is sort of a cousin of obeticholic acid. And the inclusion criteria are relatively standard. One thing though is higher ALT was an expectation in both men and women. And the disease group, once again, is limited to stage 2 and stage 3 fibrosis. And this is the treatment, the the trial design, 50 patients were randomized to each group. 140 micrograms per day and 200 micrograms per day are the treatment, active treatment. These are the primary endpoints. Once again, histology data are what Arun presented at the liver meeting. And very high discontinuation rate. This is a, mind you, this is a 48-week study, but if you look at about 30% dropped in tropifexor 200 microgram dose, and that is a high dropout from my experience. And there was body weight loss, more so than obeticholic acid within a year. But MRI PDFF, it is interesting. At week 12, this compound had significant reduction in hepatic fat. You see the same thing at week 48, but histologically, not much action here. This is NASH resolution showing, we are talking under 10% here using the FDA definition, using just the pathological pattern definition. Is about 20%, and these are not statistically significant. And fibrosis, once again, the same story, histologically no efficacy. And there are, as you would expect, there is pruritus, there is higher discontinuation due to adverse events in the tropifexor. Bottom line, I think tropifexor was a disappointment. And then my own prediction is FXRs, I think, are probably not going to be mainline, even with the second and third generation. Because when you have efficacy, you're going to have side effects. If you don't have side effects, then you're not going to have efficacy. That is sort of my prophecy. Let's see how that's going to play out. This is a trial that I think is very interesting. Aldafermin, NGM 282, Stephen Harrison presented very exciting results. This is an FGF19 analog, also impacts many key mechanisms of NASH pathogenesis. And this is a placebo-controlled trial, 1 to 2 randomization. This is a once-a-day injection. This is a FGF19 sub-Q. This is a 24-week study, but 5 MRIs at baseline, week 6, week 12, week 24, and week 30. A biopsy at baseline and a biopsy at 6 months. Primary endpoint, though, is improvement in liver fat, but secondary endpoints are liver histology. An interesting aspect about this molecule is just about everybody who gets FGF19, their cholesterol goes up. So the trial, the way the trial is designed is at week 2, if your LDL goes up by more than 10 milligrams per deciliter, automatically they get put on rosuvastatin 10 milligrams per day. Is an interesting thing about this particular molecule. Profound benefits from a liver fat, whether you look at absolute liver fat concentration, relative drop, or for example, if you look at relative fat concentration drop by 30%, which is sort of an important threshold. When your fat drops by more than 30% relatively, that's when you start to see liver histological improvement. 2/3 of the patients achieve this wonderful threshold. And then you also start to see, within 6 months, you're starting to see clinically significant improvements in fibrosis and resolution of NASH. Due to sample size, I don't think these hit p-values, statistically significant p-values. But Stephen Harrison pointed out, when you look at combined endpoint of improvement in fibrosis along with NASH resolution, these were statistically significant and seem like reasonably safe, well tolerated, but 90% of patients require rosuvastatin. So this isn't really FGF19 therapy. This is FGF19 plus a statin therapy, I must point out. Just sort of last few minutes, let me just sort of touch on a few single sliders. This is efruxifermin. This is a long-acting fusion FGF21 protein. As you may remember, FGF21 has anti-fibrotic effect, may also have insulin sensitizing effects. This is a once a week study. This is a shorter term study of 16 weeks. This, I believe, was presented by Stephen Harrison again. Primary endpoint was MRI. Interestingly, if MRI primary endpoint was met, patients ended up getting a liver biopsy at week 16. What you see here is really striking reduction in hepatic fat at week 12. And those who received liver biopsy at week 16 had histological improvement. But because of the way they designed the trial, there weren't very many patients in the placebo group that received a biopsy, because biopsy was done only in those who had MRI improvement, right? The placebo group did not enjoy that response rate. Therefore, the numbers for histology are a bit wacky. But what I see is, especially with 50 milligram, maybe a sweet spot in terms of NASH resolution as well as fibrosis improvement. Once again, within 4 months or so, this is a sub-Q once a week. I believe this is moving forward to longer term studies. Rohit Lumba presented this first-in-class fatty acid synthase. This is really important, this enzyme for de novo lipogenesis, which accounts for up to 1/3 of liver fat. And what you're showing is, this is, I believe, a 12-week study showing within 12 weeks, this particular proof of concept study showed significant reduction in hepatic fat, seemed like well tolerated. My understanding, this particular compound has been moved to a phase 2B with a longer duration of therapy and liver histology as the primary endpoint. And this is seladelpar, which is the PPAR delta. This is CINABATE trial, histologically negative study. False alarm in histological lesions led to study termination. So this is a disappointment, and I think isolated PPAR delta, I think, is not going to work for NAFLD in terms of improving histology. Last two notable mentions. First I show here is an adenosine A3 receptor agonist. This is a trial from Israel showing in a short-term 12-week study, this improved the aminotransferases as well as liver volume. Strangely, they chose liver volume on MRI, but safe and well tolerated. The authors told me that they are moving into histology trial. Resolve-it is elafibranor. This is GenFit. Unfortunately, this really large study was just a poster. As you all know the story, this was a histologically negative study. Finally, this is my final slide. Naim Al-Khoury presented this combination of adding either ACC inhibitor or FXR agonist to semaglutide. Bottom line, adding these to either one or both did not add much in terms of hepatic fat improvement, but there seems to be some liability, especially with ACC inhibitor, where one patient had serum triglyceride over 500 milligrams per deciliter. So my take on combination that are based on semaglutide, I don't think you're going to see combination trials where you add on either ACC inhibitor or FXR. Maybe other compounds, maybe added, time will tell, but the semaglutide, I think, is going to be a backbone for therapy, in my opinion, in upcoming studies and perhaps even in clinical guidelines. That's my last slide, and I want to thank you for your attention. And this is truly a privilege to be speaking to your group.
Oh, thank you, Dr. Chalsani. I think that was a nice overview of where the drugs in the pipeline. There are a couple of questions that I would like to just raise. Number one is, all trials are effectively focused only on that group of patients who have advanced fibrosis, who are likely to progress to early cirrhosis, F4 or early cirrhosis. This really forms a very, very small subgroup of patients when you look at the overall spread of patients with NAFLD in our practice. So what is going to happen to the rest of the large group? They seem to be like nobody's much interested in trying to address something upstream before this degree of fibrosis has set in. That is one question. Second question is, again, you have a group with diabetics and non-diabetics. So most of the trials are including diabetics. And then we know that once in diabetes, the pathophysiology is different. If you're able to bring down HbA1c, that by itself is going to be an independent predictor of improvement of fatty liver, etc. So isn't it time that we segregate diabetics and non-diabetics? Because in diabetes, you have a different goal along with clearance of NASH, but in non-diabetics, the entire focus is on the liver. Would you like to comment on these two issues?
Yeah, absolutely. I think really you bring up excellent point, Shiv Prasad. The first one is why the trials are limited to stage 2 and stage 3. That is the subgroup where we know the natural history. You know, stage 1, NASH with stage 1 fibrosis, I don't think we know what's happening to them. There's a paper from Arun and the NASH CRN. The patient's histology is improving. So as many patients going back to no fibrosis, even NASH is resolving. So I think it is to do with the natural history. The second is about diabetic versus non-diabetics. I think you want a compound that can affect both diabetics and non-diabetics. And I think semaglutide class of drugs are in that bucket. But some things like vitamin E may be just non-diabetics. But I think ideally you would like something that's going to work equally for both diabetics as well as non-diabetics. Okay.
Just another query. The aldafermin study was showing a 0% response to placebo. Isn't that unusual? Generally, you see some response to placebo. And was the fact that there was 0% response to placebo the reason for some significant results in that study?
Quite possible. That's quite low response rate. That's a good observation. That's why I think these are early proof of concept studies. We just need a longer term, larger powered, well-powered studies to see if this is really going to play out.
And there are no trials with glifosins in NAFLD because glifosins have been shown to have hepatic fat clearance independent of A1C reduction also. But again, I'm not seeing much interest in using glifosins in NAFLD and NASH.
If you actually look in clinicaltrials.gov, you see some trials, and I think they're just not moving forward just because you're not seeing the robustness in terms of hepatic fat reduction and ALT reduction. So the companies are not excited. When you see NGM 282 at 16 weeks showing all these Manhattan towers, smaller improvements are scaring the drug developers. So that's, I think, is why. I think there's going to be a subgroup, all these SLGT1 will play out, but I don't think that's the potency is the issue at the moment. Okay.
Would my co-chairman want to make any comments? Sandeep, you're online.
Yeah, Shiva, am I audible?
Yeah, please go ahead.
Okay. My question to sir would be that among all these new molecules, which would he give us a rough assurance? I know it's difficult, they're too early. Would be a likely promising one of them?
Dr. Rao, I would say semaglutide seems very promising. It's already approved in the US. So it's gone through rigorous testing. There aren't any unexpected side effects that are going to come up. There is weight loss. So I think that is one exciting thing, especially if they can come up with a formulation that's longer acting. If they can pegylate semaglutide, once a week injection could be quite effective in my opinion. Lanifibranor, as well as saroglitazar, if he's been tested, at least in North America, in a longer duration trial, could also be exciting.
Thank you.
Thank you so much.
Okay, there are no other questions in the chat box. I think with that, we can move on to the next part of the symposium. Thank you so much, Dr. Nagachalsani. It's always a great pleasure listening to you. And this was really a great opportunity that INASL has provided for you to speak to us.
Thank you.
Sandeep, would you like to take the session ahead?
You carry on, I'll join in, sir.
Yeah. Okay, the second part is a case-based panel discussion on NAFLD. And the moderator is Dr. Ajay Duseja, who is professor and head Department of Hepatology at India, as you all well know. And on the panel, we have Dr. Shivram Singh from Cuttack, former president of INASL, Dr. Arka De, who's assistant professor of hepatology at PGIMER, Dr. Sanjay Satpathy, who's associate professor of medicine at the North Shore University Hospital, Chicago, and Dr. Narendra Chaudhary, the senior consultant at Medanta, Gurgaon in hepatology. And I think now I'll pass it on to Ajay. Please, would you like to go ahead? And with your permission, maybe as chairman, we can also participate a little in the discussions with your permission.
Yeah, absolutely. Let me just share my screen first. Yeah, just a minute. So are my slides all visible? Let me.
Yes, you're fine.
Okay.
Please go ahead.
Yeah. Okay. So at the outset, I think my sincere thanks to Dr. Kaushal Madan, Dr. P.N. Rao, and the whole organizing committee of INASL 2020 for giving me this opportunity. So I have 30 minutes to discuss about the fibrosis assessment and treatment in fatty liver disease, NAFLD. So, and we heard that we have 4 eminent panelists with us. I think I can ask them to switch on their audios and videos. So I'll start straight away with the case and the.
Dr. Duseja, just a second.
Sure.
I think Dr. Chalasana is also going to stay during the discussion.
Oh,
Absolutely, I
Yes,
think that's
kindly
an
agreed.
honor and privilege to have him, and I think I'll be quoting most of his guidelines. So I think he can. Yeah, sure. So let me start with the case. And this gentleman, this is a real life case, 51 years old, male, non-alcoholic, non-smoker, had diabetes, hypertension, and dyslipidemia for almost 8 to 10 years, on oral drugs, presented to us, and his average body weight in last 10 years had been around 90 to 95 kgs, and he had elevation of transaminases, and that is what he basically the evaluation he came to. So examination, he was normotensive that time. He was on telmisartan for blood pressure, high blood pressure, and his BMI was 31.9, which is for Asia Pacific, for Indian standards, would fit into class 2 obesity. And his waist circumference, again, I think he was centrally obese. So 90 centimeter is the cutoff for Indians or Asians we take. The physical exam, he had palpable liver, nothing rest was remarkable. And the lab showed that his platelets were 150,000. His electrolytes and renal functions were normal, and his liver functions revealed that his enzymes were minimally elevated, 64 and 48. Albumin was preserved, and he had normal fasting sugar and lipid profile. But as I said, he was on anti-diabetic, a combination of metformin, sitagliptin, and atorvastatin already. We worked him up for secondary causes, and he turned out to be negative for Hep B and Hep C, and also was negative for autoimmune markers. His iron profile and ceruloplasmin was normal, and ultrasound had shown hepatomegaly with severe steatosis, grade 3 ultrasound, and rest all was normal. So what I have done is I have divided this now into, 2 parts. One is 2 questions we'll be discussing predominantly on the fibrosis assessment, and the 2 questions we'll be focusing on the treatment part. So my first question goes to Dr. Sanjay Satpathy, and I would request him to clarify that if you get this kind of patient who has metabolic syndrome, is obese by Indian and by even the Western definition, and now I've given you the labs. He has minimally elevated liver enzymes. His platelets are 150. So what would be your approach in assessing? We are restricting ourselves only to fibrosis assessment. So what would be your approach in assessing the hepatic fibrosis in this gentleman, or anybody like this who presents to you, of the various, non-invasive, scores available, the patented and non-patented? What is your, clinical approach, or what is your clinical practice, and what would you tell the audience that we should be doing? And simultaneously, I would also ask you about the role of elastography here, whether you would like to do it, if yes, sequentially after using these scores, or simultaneously. I think maybe you can throw some light on this. Dr. Sanjay Satpathy, are you there?
Yes, I'm here. Can you hear
Please.
me?
Yeah, sure, I can. Yeah.
Yes. Well, I think this is such an important case, especially, the vast majority of the cases that we see are probably fall into this. And as we always have difficulty enrolling in clinical trials, the stage 3 patients. So if you see, most of these patients fall into this category to find out whether they have advanced diabetes or not, right? That's what we are trying to determine, this patient has advanced fibrosis or not. And we have so many of these non-invasive markers of fibrosis. So I would, before I decide which test I will use to screen them for advanced fibrosis, why don't we first, let's look through all this. What are the scores actually? First, the ELF score, right? The ELF score actually is a score based on three panels. Three is a panel based on three molecules, right? P3NP, hyaluronic acid, and TIMP1. These are direct complement of the fibrosis, right? Hyaluronic acid is an important structural role in, it plays an important structural role in extracellular matrix. P3NP is a direct measurement of the synthesis and degradation of existing fibrosis. And we have the TIMP1, which is reflective matrix remodeling of the fibrogenesis and fibrolysis. So these are all direct measurements of fibrosis. So obviously, this will be one of the best tests in terms of measuring or quantifying the fibrosis. In fact, the study that was done, it has an OROC of 0.92 for F1 fibrosis, for 0.98 for F2 fibrosis, and 0.99 for F3. So even you can quantify the stage of fibrosis using ELF, and many of the clinical trials that has been using in the drug trials, they're using ELF because of that. But the problem is the ELF it's not widely available. So in a resource poor setting, it is not possible to use the ELF. But if I give it a choice of all this, probably ELF is one of the best ones. So I would actually consider using as a good screening tool to ELF, especially if I'm enrolling a patient for a clinical trial. I think ELF would be very helpful in terms of finding out who had advanced fibrosis or not. Coming back
Let me just interrupt you, Sanjay here. Will you straightway go for ELF? And you rightly said about the availability and the cost, and it's a patented test. Or would you like to do some of the tests which are available on your bedside, like FIF4, NFS, or and then go for ELF?
I absolutely, there is no reason to go to ELF. I think if you have a screening tool available, because all these are screening tools. I don't think these are tools that we can, as a comparison to liver biopsy, is a gold standard. So you do one of this or two of them in a combination and then go for a biopsy, right? So in a resource poor setting you're talking about where you don't have that, I would actually see, we have EPRI, we have FIF4, we have NFS, right? So EPRI, let's talk about FIF4 because FIF4 has age, AST, ALT, and platelet, 4 parameters. And NAFLD, who is NFS, has 3 additional ones. What do we have? We have BMI, diabetes, and albumin. You have added 3 more. So obviously, the sensitivity increases when you go to NFS as compared to the FIF4. So I would, in terms of the sensitivity, it looks like the NFS is 73 to 82%, and specificity is almost 96 to 98%. Both FIF4 and NAFLD, they works very good in this way, right? So in a resource poor setting, I will use those 2 tests. And then if they are, then if I'm still in the indeterminate range, because these are dual cutoffs, right? Though both have dual cutoffs. So if you are falling in the indeterminate range, I would try to get another test in that setting.
Okay, and how about the elastography? Where will you place the elastography in, while you're assessing this kind of patient?
Well, you're talking about transient elastography, which is, the elastography just in general could be MR elastography or a transient elastography. We have point shear wave elastography. There are
any ultrasound-based elastography for that.
Yes. So in ultrasound elastography is an excellent tool, and particularly if I combine this FAST score, which I'm talking about, the FAST, which is an AST with a FibroScan, when you combine them together, you can identify, because the score was designed, the FAST score was designed to find out patients who are more likely to be progressive disease, more than F2 fibrosis, and a NAS more than 4. That's how they designed it. So that may identify a patient who are more likely to have progressive disease. And once the drugs are available, I think the FAST would be a very useful screening tool where you could potentially go for a biopsy and then look for the treatment, because otherwise you'll have a lot of patients who will have biopsy and doesn't necessarily need treatment.
Okay, let me move now and I'll come to Dr. Chalasani and other panelists also in a short while. But let me just show you, and this is one I picked up from the review article written by Professor Chalasani. And I think this is the, the kind of, the algorithm which was, published 2 years back by them. I think if you have, NAFLD, and you have done the NFS and FIF4, and if it is ruling out, the what we call the advanced fibrosis, because all these scores, I think, let me just put it that they would have better negative predictive value than positive predictive value, number one. But then, and also, I think this was pointed out by Professor Shiva, I think in the last presentation, that majority of the patients are maybe 60% would be where those who do not have advanced fibrosis. So we are basically targeting this around 15% of the patients, those have advanced fibrosis. So when you do the NFS and FIF4, and if you are ruling out the advanced fibrosis, if the FIF4 is less than 1.3, and in the Indian setting, I think we have a paper where they said it could be 1, but that is for significant fibrosis, not for advanced fibrosis. And if the NFS is less than minus 1.445, I think you can just kind of, observe them. But if you have, a high intermediate, then I think probably elastography, maybe a transient elastography or MR elastography or ELF and all could be done. But this could also be dependent on, I think, Sanjay, if you would agree with me, the kind of, setting you're working with. I think this is one paper which I picked up, again, from a primary care level. So at a primary care level, I think it is good to use NFS or FIF4, right? And then if you find, again, if it is a low risk, I think you can just, manage them at a primary care level. If it is a high risk for, say, F3 or more fibrosis, they need to be referred to a tertiary care center. Or if it is indeterminate, I think probably then the ELF. And this is one, I think, paper which as a Go Asia group, we had published last year from 10 centers in Asia. And where we said that you use the NFS and FIF4 first, and again, depending upon the kind of advanced fibrosis you are thinking, if it's a low prevalence, and then followed by elastography, that probably is helpful. But then if you are already working in a tertiary care setup and you think that this patient is likely to have advanced fibrosis, you can directly go for a fibroscan also, and a cutoff of 10 or more would actually give you a good, sensitivity and specificity for, ruling in advanced fibrosis if you're suspecting somebody having advanced fibrosis. I think maybe we can have some discussion on this. So maybe this was the patient which we said. So this is the APRI which was calculated, 0.89, and anything more than 0.7 is significant. More than 1 is, again, I think, suggestive of, this advanced fibrosis or cirrhosis. This was FIF4 closer to 3.25, which is the cutoff for, advanced fibrosis. This gentleman had 3.14. And the NFS was again 3.44, again high. So again, I think Dr. Sanjay pointed out at the FAST score, which is a recent publication from UK, where they use, the LSM, gap value, and the AST. And we calculated in this patient, it came as 0.62. And this is very helpful in knowing the patient about NASH with NAS of 4 or more and F2 or more fibrosis. But let me just point out here that we recently, looked at our own data, and Dr. Arka is there with me, and this is, under publication. And we found that I think these cutoffs which were given by the original publication by the NewSem about the FAST score could vary from population to population. And this probably would also apply to various other scores also. And let me bring in Professor Nagachalasani here and take his opinion about the population-based cutoffs, which would vary for all these scores. Should that also be taken into consideration, or this could be all universal?
No, Ajay, these are not. Can you hear me?
Yeah, we can. Yeah.
Yeah, these are not universal. I think we know children versus adults, these cutoffs change, as well as BMI, diabetics versus non-diabetics as well. So I think your point's well taken. And I think they're doing exactly what should be done, trying to get some data that are standards for like Indian population. But I mean, if you just look at this particular patient, a couple things in just the blood work, AST-ALT ratio is reversed and the platelet count is low. That is sufficient to say, hey, this patient is going to be in trouble. He has to do one or two things. Either has to really lose 10% body weight, 10 to 15%, or get a biopsy. But I'm, so bedside, I think without doing a whole lot, you can tell the patient about the urgency. That's one. Second, I'd like to draw your attention to a cost-effective analysis that was published in CGH maybe early this year about the sequence that you're talking about. I think of all the sequences that you presented, probably the one that is most cost-effective is FIB4 followed by transient elastography.
Right.
That is probably what should be done. Sanjay, I agree with you about the ELF, but ELF isn't not available in the US. And my understanding is Siemens tried to get approval from the FDA and they did not receive approval. So I don't think, at least for next couple of years, we're not going to have ELF in the US. And I'm not sure, is it available in India, ELF?
No.
I mean, it's really a few parts of Europe and the United Kingdom where ELF is available. So I'm a fan of FIB4, given just the amount of data we are seeing and its longitudinal relationship with outcomes.
Okay, so I think, as he said, this gentleman again had, scores which were suggestive of, advanced fibrosis. And as I said, we don't use any of the patent, the test for fibrosis, and we always just do the FIB4 or at the most NFS, and then, we decide on the biopsy. So based on this, let me go to the second panelist, Dr. Arkade, who's in the department with us. Dr. Arka, are you there?
Yes.
Okay, so my question to you is, now having given you all these values of, the APRI, FIB4, and, the NFS, which we did in this patient, and obviously we didn't have the fibro test, ELF and all, and the fibro scan, the LSM was 10, CAP was 290, and the FAST score also available. Will you subject this patient to liver biopsy? If yes, what are you looking for in the histology in this particular patient, and how will this change, the management in this particular patient?
Right, sir, I think I will be subjecting him to liver biopsy in ideal settings. And if you really look at the guidelines, if you look at the ASLD guidelines, there would be two scenarios largely in which you will be considering liver biopsy in a patient of NAFLD. One would be if there is some diagnostic doubt as to whether it is really NAFLD or there is some alternate etiology, which I do not think is a scenario in this patient. In this obese patient with a BMI of 31.9, who is diabetic and with a CAP of 290, definite steatosis and everything. So I do not think that there's any doubt that the patient definitely will have NAFLD. And the second reason for performing a liver biopsy as per the ASLD guidelines would be that the liver biopsy needs to be targeted at patients who are likely to have steatohepatitis or advanced fibrosis. Now, I think the patient really fits into both of these things. All the parameters that we have, the non-invasive parameters, they are suggestive that the LSM is 10, so it's suggestive that the patient likely has advanced fibrosis. The FIB4 was 3.2, so but if we take the cutoffs of FIB4 in NASH, we often take the cutoff as 2.67 instead of 3.25. So that is also fitting into the zone of advanced fibrosis. And as far as steatohepatitis is concerned, so even though we have made so much of advancement in various non-invasive methods for staging the amount of fibrosis, I think for steatohepatitis, biopsy is still the go-to thing, still the gold standard for detecting whether steatohepatitis is present or not. Some non-invasive scores, like we discussed, the FAST score, and recently also a NIS4 score has been published in Lancet. The NIS4 uses very proprietary molecules. It requires microRNA, so I don't really think it's going to come into practice in the Indian scenario. The FAST score is very attractive because it tells us not only about the fibrosis, it tells us whether the patient is also likely to have steatohepatitis, the NAS score of more than 4. And the real point is that whether you look at the Newsom study or our data, the OROC, the discriminating power of the FAST score is very, very high. It is almost 0.9, more than 0.9. The issue really is about the cutoffs and the rule-in cutoff. So whether the rule-in cutoff of the Newsom study we take 0.68 or the cutoffs that we found, which are a little higher, the positive predictive value is still in the range of only maybe around 70 to 80%. So those patients who come in the intermediate zone of the FAST score or even in the rule-in zone of the FAST score would still actually merit a biopsy to confirm whether they really have steatohepatitis or not. And so this patient would merit a biopsy because he's got a very high likelihood of having advanced fibrosis and also steatohepatitis. Even clinically, we could predict that he is at a high risk of having NASH, given that he's got the multiple metabolic risk factors for obesity and diabetes. And in the histology, the things that we would be looking for is to confirm a diagnosis of NAFLD. So the presence of steatosis in more than 5% of the cells would tell us that indeed this is NAFLD that we are dealing with. And then whether the patient really has got NASH or not. So the presence of lobular inflammation and hepatocyte ballooning. The presence of both of these would be the hallmarks that would be telling us that this patient has NASH. And lastly, the biopsy with all the caveats of the sampling error, it would give, also tell us about the stage of fibrosis in the patient. And all of this will not only help us in prognosticating the patient, because we know that fibrosis ultimately will determine the outcomes of the patient. But with respect to treatment, we could try and put them on pharmacologic therapies for NASH, particularly vitamin E. In such an obese patient, I don't know, pioglitazone may not be a very good choice, but we could consider, and he's diabetic also, so we could consider saroglitazar in an Indian setting, and otherwise vitamin E. So,
yeah, thank you, Dr. Arka. I think your points are very well taken. My only worry is with the suggestion of MAFLD coming in now, and then they are, getting away from the steatohepatitis or NASH. I'm a little worried on that, but this I think is very, very important that I think the NASH and the fibrosis and the biopsy is so very important. And these are the, the recommendations by the ASLD, Professor Chalasani is there. I think if you suspect somebody having advanced fibrosis or steatohepatitis, which is based on the presence of metabolic syndrome, NFS, FIF4, or elastography, or if you have a competing etiology, yes, they would require a biopsy. So a liver biopsy was done in this gentleman, I think, and if you can appreciate the ballooned cells here, I have not shown you the picture of lobular inflammation. And look at this, I think this beautifully has shown us the stage 2 fibrosis. This is the, the portal fibrosis. This is the perisinusoidal. So I think when both are there, I think we call it as stage 2. And this is the Mason's trichome stain, and this is the reticulin stain here, again showing us the perisinusoidal and the periportal fibrosis. So this confirmed that he had an NAS of 5, so NASH with F2 fibrosis. So my question now to the next panelist is, Narendra, are you there, Dr. Narendra Chaudhary?
Yes, sir.
Yes, Narendra. So the question to you is, I mean, he had metabolic syndrome, he's obese. So the first line, obviously, and then the biopsy shows us NASH with F2 fibrosis. So what kind of lifestyle interventions would you advise to this patient? And thereafter, if you want to consider any bariatric, endoscopic or bariatric surgery on him after the lifestyle interventions have failed, or I think you can just elaborate on this. Yeah.
Sir, lifestyle interventions are diet and exercise. I would suggest him a 500 to 700 kilocalorie deficient diet than what is required for him every day. And in particular, to avoid fructose, I would advise a 45-minute, at least 5 days a week, brisk walk or jogging as exercise. So most of data is available on aerobic exercise, but there are some studies on anaerobic exercise also that is equally efficacious if a person can do. So bariatric procedure.
No, but before you go to bariatric, Narendra, how much weight reduction are you looking for in this patient? And what do you think, what percentage, or is he likely to achieve that? Number one, and over what period of time are you looking for that weight reduction?
Sir, at least 7 to 10% weight in next 6 to 8 months. But studies have shown that fibrosis and NASH resolution, it happens more commonly if there is more than 10% weight loss as compared to 7 to 10% weight group. So target is at least a 7 to 10% in 6 months. But if
that person can lose more, that is better.
So what are the chances, or what does the data tell us, that what percentage of patients on lifestyle interventions are likely to lose that amount of weight, say 7 to 10%?
Sir, 7 to 10%, actually most of patients don't achieve this target. Also, once this target is achieved, there is tendency to weight gain in future.
Absolutely. Okay. So I think, so to at the outset, would you consider the bariatric procedures or no, or you will consider them only once the lifestyle interventions have failed, or what?
So bariatric procedures have shown to decrease NASH also, fibrosis also. But in these studies, bariatric procedures were done primarily for other indication rather than to treat NASH. So if patient is eligible for bariatric surgery for other indications, then I am happy to advise him for bariatric procedures. Just for NASH or fibrosis primarily without other indications, no. So first it is lifestyle not improving, and if patient is candidate for bariatric surgery, otherwise then yes for bariatric.
Okay, I think because we are running a little short of time, and I'll come down to our US experts. But let me first, I think go to the. Let me skip all this about the indications for bariatric and all, and let me now, I think, ask the last question, and then we can have a combined discussion to Professor Singh now, who is with us. I think. So, Dr. Singh, can you just tell me now, he's NASH, biopsy with F2 fibrosis, lifestyle interventions, and the control of metabolic risk factors are happening. We are trying to control his diabetes, hypertension, dyslipidemia, which is part and parcel of, management of such patients. So, but my question to you is, pharmacotherapy, drug you want to choose? If yes, which one out of these 4 which I have listed? And when you choose any of these drugs, will you like to modify any of his current drugs which is he on? And I think you can maybe elaborate on this, and then we can have a combined discussion. You can unmute yourself, please. Yes. No, there's some problem with your audio, Dr. Singh. We can't hear you well. No. No, I think there's some problem with the audio.
Dr. Desai, there's a network issue.
There's a network issue with him? Okay,
yes.
Okay. Okay. So I think before we go and answer this question, I think maybe again Sanjay or Professor, I think Chalasani can take this up. Obeticholic acid is not approved even in US or here. Saroglitazar is not available with you in when we have a luxury at least of having saroglitazar with us. Your choice is only vitamin E and pioglitazone. And this gentleman already being obese, diabetic, and also out of the 2, if you can tell us this, and then what would be our choice in India, I think we can maybe elaborate on that later.
I can start, even if I'm in India. I did the saroglitazar trial in the US. So, but I think it is premature to use saroglitazar, even in India, just because you just don't have good histological data, long-term data. I know they got the approval. I hope they're not listening to me on this call. But so vitamin E is what I would recommend in this patient, just not because of the PREVENT trial, but also remember Eduardo Villar Gomez had a hepatology paper showing vitamin E improved outcomes in NASH cirrhotics. That's, I think, is the only trial, maybe metformin as well, where actually a therapeutic intervention changed the outcomes, including time to transplant, death rate, so on and so forth. So I think vitamin E risk benefit quite favors 800 international units of vitamin E. That's what I would recommend. Can I make just one comment though? Ajay, you and other leaders from India have to start thinking about PNPLA3 other variants. How are you going to put them into your treatment algorithms? PNPLA3, not just the prognostication, but I think it determines who responds to lifestyle modification. There are data from Mexico saying if you have GG, you're just resistant to weight loss, where unlike CC or CG. And then if you're going to use vitamin E, haptoglobin variants, I really urge you all to start trying to incorporate some of these selected gene tests variants into your algorithms.
Absolutely, I think very well said. Dr. Sanjay Satpathy, I mean, you would also agree with the vitamin E as the first choice here?
Yeah, absolutely. I would, unfortunately, we don't have a lot of choices here. The choice is pretty easy because we don't have availability of other Liraglutide or obeticholic acid is still under clinical trial. But talking about vitamin E and pioglitazone, I think I'll definitely prefer, in the same trial, the PREVENT trial, you saw the vitamin E and pioglitazone. To some extent, the vitamin E was a little better than that way. But the weight gain was the problem with the pioglitazone. The vitamin E, this is a male patient, so I'll certainly advise. There is a small controversial increased risk of prostate cancer. So certainly they need to incorporate PSA into their profile at least once in a year. But as Naga pointed out, their own study from Eduardo also showing that it improves the outcome. In cirrhotic patient, they used it. So I would definitely prefer vitamin E as the #1 choice in this. Can we add pioglitazone on the top of it? Probably not.
Okay. Dr. Singh, are you there? No. No. So, okay. So I think...
Can you hear me now?
Yes, we can hear you. So can you just tell us about your choice of drug? We have heard the US experts and they are focusing on vitamin E as the first choice here.
I'm a bit of a conservative person. And see, the patient is already on so many drugs. He is taking telmisartan, metformin, atorvastatin, sitagliptin. And he's very well managed. His lipids are fine, his blood glucose are fine, his blood pressure is fine, he's doing well. So I don't see, and all these medications have effect on NASH also. Telmisartan is known to have an effect on NASH. There are studies, of course, I mean, there's a controversy. There are studies which have shown effect on fibrosis. Metformin, of course, doesn't affect much. Atorvastatin, again, it does improve NASH, but not fibrosis. So with all these medications, unless we give a fair style of lifestyle intervention, I would not favor vitamin E addition to this patient unless we have given a fair trial of lifestyle intervention. But before that, I'm not happy with the question of liver biopsy either. Because, see, even the ASLD guidelines for liver biopsy, they have given two choices. If you have a controversy, if you are not sure that is NAFLD or NASH, or if there are, florid features suggesting that there is fibrosis. But why? The only indication that you do biopsy in these patients is if you are fishing for candidates for trials. If you are not doing a trial, what you are going to manage, try to control the risk factors, and you're going to do lifestyle interventions. You're not going to do a trial of the other drugs which are not yet in the market or which are not yet, our societies are not advocating them. So the only reason why you do is that the ASLD guidelines specify that you can use pioglitazone and vitamin E for biopsy-proven NASH. So that's the only reason for which you may do a liver biopsy. Otherwise, I don't see a reason why you do liver biopsy. You manage them with whatever modifiers of risk factors and lifestyle interventions, and you see how the patient fares on them with the scores. And
okay.
I think we'll have to wind up soon.
I'll have to wind up. Okay. So maybe if we get some time, we'll have some discussion on biopsy also. But this is how what we try to do now in our practice in India is that saroglitazar is there in India for almost now 10 years for diabetic dyslipidemia. And we have a fairly good experience of this drug in diabetic dyslipidemia about the safety and efficacy. And with the evidences for data and evidences to data in patients with NASH and the DCGI approval for NASH with F1 to F3 fibrosis. So this is my personal experience. Anybody who has diabetic dyslipidemia, But for the reason for the costs of the tablet, I think in these kind of patients, I think saroglitazar becomes, our first choice. But then, as I said, the data on fibrosis, we really do not have. And the number of patients where this has been tested and biopsy proven, as Dr. Naga pointed out, is also very small. So probably we need more data on this. But then without diabetes, I think vitamin E. So Dr. Naga, my question to you was, this patient is a diabetic. So still vitamin E, or, with or without diabetes, does it make any difference, or is it okay? And again, the effect on fibrosis in the PIVNs was not seen. It's only your retrospective data which has shown that it reduces your chances of getting transplant, or it improves your transplant free survival or overall survival. But that's a retrospective analysis. But in the PIVNs, we didn't see any improvement in fibrosis with vitamin E. So your comments on this?
Your point's well taken. If you really want to be evidence-based, you cannot give vitamin E to this particular patient who is a diabetic, because the data are on non-diabetics from the PIVNs trial. So that's well taken. I personally would use vitamin E as a practitioner just because of our data on long-term outcomes. But I would like to point out, though, now that you have saroglitazar in India, maybe you should do head-to-head trial between vitamin E and saroglitazar, 1 year endpoint, even longer duration, because I think you're well suited to test.
Yeah, I think we are probably on that. And so I think pioglitazone probably we will not consider here for various reasons. And as I said, the OCA is not available. So I think the choice would be between this. So I think let me just find out what I said in last, I think we discussed. So hepatic fibrosis assessment is very, very important. The initial assessment has to be non-invasive, and maybe FIB-4 and NFS as the initial scores, and followed by fibroscan, which Dr. Naga also agreed, and liver biopsy we can have maybe discussion later. But I thought whether this patient would have turned out to be F3 or F4 versus he turned out to be F2 on fibrosis on liver biopsy, I think the biopsy did have a role to play in this gentleman. And finally, as far as the treatment is concerned, so other than the control of risk factors and the weight reduction and the lifestyle interventions, the drugs, I think, as I said, the choice would be only between vitamin E and saroglitazar as per the availability. So thank you very much for your, participation and kind attention and everything. So maybe I think if we have some more time, maybe 2-3 minutes, any questions from the audience? Dr. Shiva, if you want to take that, or it's okay.
I think
we are running out of time, and
okay. You need to unmute yourself. Dr. Shiva, you need to unmute yourself.
Yeah, there are no questions in the chat box, and I think we are running a little beyond time. So obviously the biopsy point is, I would support what Shivram has said, that outside a clinical trial and outside a diagnostic dilemma, it'd be extremely difficult to justify doing a liver biopsy in routine clinical practice. So I think that point is valid in the sense, like you may talk about it and you say the benefit that you get from it, but actually do it in clinical practice is very difficult. So with that, I think we come to the end of this very fruitful session. And I think there was a single case gave us a lot of learning points and teaching points about how to approach and manage NAFLD. Thank you, Ajay. And thank you all panelists for a very enlightening discussion. Kaushal, it's back to you.
Thank you very much.
Yeah, thank you so much, all the speakers and chairperson panelists. We had a wonderful discussion on NAFLD. So now we move on to the Hepatitis B Symposium. And for that, I would like to invite the chairpersons for the session. We have Dr. G.N. Yattu, who is the professor and head, Department of Gastroenterology, Sher-e-Kashmir Institute of Medical Sciences, Srinagar, J&K. We have Dr. Chirag Desai, who's the Chief Consultant and Program Director, Department of GI, HPB and Liver Transplantation, Apollo Hospitals, Ahmedabad, Gujarat. And we have Dr. K.T. Shenoy, who's the Professor and Head, Medical Gastroenterology, Sri Gokulam Medical College and Lord's Hospital, Thiruvananthapuram. So welcome, chairpersons, and over to you to take the proceedings forward.
Good evening. Am I audible?
Yes, sir, you are.
Yeah, I have a great pleasure in inviting Paul Tulawat, who is actually from Kerala and currently in the US in the Department of Gastroenterology and Hepatology at Baltimore. He is a very senior professor and a director of the training program, and he has done many pivotal studies. And of late, I think one of his studies is on COVID and liver involvement. So we have a great pleasure in welcoming Paul to this meeting, and he is going to deliver the lecture on advances in hepatitis B and what has gone from the ASLD. Dr. Paul?
Thank you. I have an apology to make. I won't be able to stay for the discussion part because I didn't realize there was going to be a discussion at the end of this. So I want to thank INASL, Dr. Kaushal Madan, and others for asking me to give this debrief on hepatitis B. I have few conflicts, but none directly related to my talk. I'm just going to go through some of the important presentations at the recent ASLD meeting. I selected about 7 abstracts, some of it related to the conventional treatment, some new treatments, and probably some for the future. The first study I selected is a randomized controls trial looking at pegylated interferon, the role of interferon in combination with tenofovir for management of hepatitis B. The primary endpoint was hepatitis B surface antigen loss. And this was a 1-to-1 randomized controls trial, tenofovir versus combination treatment. The combination was given only for the first 24 weeks. Then tenofovir was continued for the next 4 years. Patients were stratified by E antigen status, HPV genotype, and cirrhosis. After 4 years, they were eligible for withdrawal from the tenofovir. And they had to fulfill certain criteria as shown here. DNA should be less than 1,000 IU. They should not have cirrhosis. E antigen should be negative by week 144, hepatitis B antibody positive by week 18. And the primary outcome, we'll focus on the primary outcome, surface antigen loss. And the patient could restart the treatment if they have decompensation, elevated ALT, or DNA more than 10,000 IU. I think the surface antigen loss, as you can see here, was dismal. At year 4, 1% in the tenofovir group versus 4 in the combination. But year 5, they were identical. There was no difference in surface antigen loss. There was a trend towards a higher E antigen loss, but not statistically significant. Other parameters were similar. When you look at the ALT flares, as expected, in the first 24 weeks with interferon, there was a higher ALT flare in that group. But when the TDF was discontinued, there was a higher flare up in the tenofovir alone group. But the bottom line is, addition of interferon did not improve the surface antigen loss or E antigen loss. So I think we can put to rest the role of interferon in combination with nuke for surface antigen loss. This is a well-conducted study, 5-year data, and I don't think interferon has any role to improve the surface antigen loss or the functional, to improve a functional cure. Next study was looking at the surface antigen loss in Asian versus Caucasians. There is a perception, at least there has been studies that show that Asians are less likely to lose a surface antigen compared to Caucasians. So this was a retrospective study from 3 continents, North America, Europe, and Asia. They selected a large cohort of patients. the patients have to be E antigen negative at the end of nuke cessation. It was collected over a period of 20 years. They excluded co-infected patients or those who had interferon. And unfortunately, majority of these patients were Asians. Only a small percentage were Caucasians. And at the onset of treatment, 77% were E antigen negative. And after 3 years of nuke, the treatment was discontinued, and they looked at the relapse rate as well as surface antigen loss. This is, you cannot compare with the previous studies because patients were entered at multiple stages here. So 4-year surface antigen loss was good here, 14% compared to 4 to 5% in the previous study in the randomized controlled trial. But when you look at the univariate analysis, older people, those who were male, there was statistically significant on univariate analysis with age, but gender did not make any effect. But Caucasians were more likely to lose a surface antigen compared to Asians. In a multivariate analysis, this was confirmed. So this more or less confirmed the general feeling that Asians are less likely to lose a surface antigen. They're less likely to have a functional cure compared to Caucasian. It could be at the age at which they contracted, the way they got the hepatitis B, or maybe some genetic variation. So Asians seem to be less likely to have a functional cure. Majority of patients, 74%, had a relapse when the nuke was discontinued, and about half of them, 56%, had elevated liver enzyme, which made them restart the treatment. What are the limitations? It was a prospective study over a period of 20 years, and only a minority were Caucasians. So I just put a slide, just summarize 2 studies. I won't go into the details of these studies. One was using TAF instead of tenofovir, TDF, for prevention of hepatitis B in highly viremic mothers with chronic hepatitis B. You know that tenofovir, TDF, is a class B pregnancy drug, and TAF has not been tested, although similar molecule. So in this one, they just wanted to test whether TAF is as safe as TDF. A relatively small study, 71% with highly viremic pregnant mother. They were given in the 3rd trimester TAF, and 71 mothers had 73 infants, 2 were twins, and none of the infants were infected, and there were no birth defects and no safety concern, suggesting that TAF could be used instead of TDF if necessary in pregnancy. Next one is looking at the GFR changes with tenofovir versus entecavir. And you know, the reason they introduced TAF was because there is a potential risk, renal toxicity with tenofovir if it is used on a long-term basis. This is a retrospective study, large data set, about 5,000 patients. The change in tenofovir related renal function was minimal. If you look at it, 1.2 to 3.1 ml over a long period of time. And they also looked at the decrease in the CKD stage by one stage decrease. And in a multivariate analysis, tenofovir was associated with worsening by 1 stage. So the bottom line is, if the patient is at a high risk of developing renal dysfunction, you could either use entecavir or perhaps use TAF instead of TDF. Now, going back to some of the basic science, one of the questions what people were asking is nuke helpful to reduce the integration of HPV DNA into the host genome? The integration takes randomly, occurs very early. I will show you another study which shows that it happens soon after the infection. And it induces hepatocellular carcinoma by acting on the HCC genes and causing chromosomal instability. And nukes reduce the intrahepatic and serum HPV DNA. Aim of the study was to explore if it affects the HPV DNA integration. So well-conducted study, 28 patients, 14 were E antigen positive. They were on a variety of drugs. All had liver biopsy at baseline and at 1 year. 5 had third liver biopsy at 10 years. And the DNA integration was detected by inverse PCR and expressed as hepatocyte clone size. So at baseline, all patients had DNA integration. Clone size did not correlate with E antigen status or DNA level. And it was found in all chromosomes except Y chromosome. And as you can see in this table, at year 1 and 10, all the parameters except the surface antigen showed significant decline, including the intrahepatic cccA DNA and intrahepatic DNA. This is a clone size, the integration. From compared to baseline, there was a significant reduction at year 1, almost 42.5% reduction in the clone size. More importantly, 3 of 5 patients who were liver biopsy at 10 years had undetectable HPV DNA integration. So this shows that nuke treatment, long-term treatment may reduce the clone size of infected hepatocytes and the DNA integration, but there was no correlation between serum or intrahepatic HPV DNA and cccDNA with this integration. On the same line, another group looked at the using a different technique, RNA sequencing method. This is a part of a randomized control trial. They had two biopsies at year 0, baseline, and year 3. And just as in the other study, they had about, they compared with a placebo versus, this is a better study, about 120 patients had a paired biopsy. And the technique used was slightly different. They used RNA sequencing called RNA-seq. And there was a good correlation with integration with other various parameters like DNA, surface antigen, RNA, and core antigen, a good relationship. And at baseline, the integration was directly related to the DNA level. At year 3, there was no relationship, partly because most patients have very low detectable HPV DNA. But this is the most important part. There was a twofold decline in the integration, expressed viral integration. And they also said dysregulated genes were less expressed. So nuke long-term seems to have an effect on the viral integration into the host genome. There was another study on the similar line, a prospective study looking at how soon the liver get infected after liver transplant in people who are transplanted for hepatitis B. This 34 patients with hepatitis B undergoing liver transplant were examined. Almost all of them were negative at the time of transplant. Blood was collected at various intervals. Liver biopsy was done at the native liver, the time of reperfusion, and 12 months after transplant. And the result showed 14, or half of them, the reperfused liver immediately after transplant were positive for HPV DNA. At 1 year, 13 of 20, almost 60% were positive for DNA. And although our surface antigen was negative in all patients by the conventional method, by Lumipulse test, 5 patients were positive. Again, confirming that the prophylaxis we give after liver transplant in Hep B patient probably need to be lifelong. This is a vaccine to see whether the vaccine could reduce or increase the surface antigen loss and a functional cure. This is a Japanese study. They developed a therapeutic vaccine containing surface antigen and core antigen. Idea was surface antigen will cause neutralizing antibody, and core antigen will stimulate the cytotoxic lymphocytes, inhibits the viral replication. They had 2 cohorts. One cohort with chronic hepatitis B on nuke treatment. Other one was the what we call carriers or immune tolerant phase. They were not on any treatment, 42 patients. The vaccine was given by a special device every 2 weeks, 10 times, and the patients were followed up till 90 weeks. The 2 panels on the left-hand side, one on the people on nuke treatment with chronic hepatitis, the other one immune tolerant people. both groups showed decline in surface antigen. And on the right-hand panel is the surface antibody. Both showed a slowly increasing surface antibody. So this reduction in surface antigen, core antigen continued even after 6 months of the treatment. And the mean reduction of surface antigen was 23% at 18 months. And more importantly, this is interesting, about 9% of patients had a functional cure. That means they lost the surface antigen and developed surface antibody. And 4 of these patients were the immune tolerant patients. I have 2 more slides. This one looking at the RNA interference agent, hepatocyte specific. They used a molecule for the entry of the interference agent into the hepatocytes. Because using the receptors, they could attach and get into, stimulate the endocytosis. This is the study they presented, not the first part, this has been shown before. Patients with chronic hepatitis B, they give a single dose of this RNA interference agent. 3 doses, 60, 90, and 180. And the third group, they had multiple doses, 6 injections. This is delivered subcutaneously. And they looked at the surface antigen levels. The one dose, single dose group, whether it is 60, 90, or 180, there was a decline in surface antigen. And all 3 groups showed that. And in the multiple dose group, the decline in surface antigen continued. And adverse events with this agent was mild. Only 22% had increase in liver enzyme. So single dose cohort, surface antigen decline until plateau at 12 weeks. Repeat dosing continued the decline. So another way we could probably achieve functional cure. These molecules are in very early phases, and we will probably see more in the future. This is my last presentation. Hepatitis D, the treatment is suboptimal. Many drugs have been tried with minimal efficacy. This was a study done by Christopher Koh from National Institute of Health. And he used a combination of peg interferon lambda because it is hepatocyte specific, lonafrenib. This is a farnesyl transferase inhibitor. What it does is it inhibits attachment of a lipid molecule to the hepatitis D antigen. That lipid molecule is important for the interaction between HDV and hepatitis B surface antigen. The ritonavir is used to increase the blood level of lonafrenib. Lonafrenib has significant GI toxicity. By adding ritonavir, they could use a lower dose. So they used a combination of this drug and for 24 weeks, 3-drug combination. And you can see at week 12, the HDV RNA decline, and it was maintained at week 24. And 3 different groups, there are a significant number of patients had more than a 2-log decline. And the side effects were as expected, mostly related to lonafrenib, GI side effects. But 77% had more than 2-log decline after 24 weeks. 50% had undetectable HDV RNA. And 23% maintained this undetectable RNA at follow-up, and it improved the liver function test. So theoretically, this is an agent we could use for HDV if phase 2 and phase 3 trials confirm this data. So I will stop here. I hope I didn't take more than the allotted time. Thank you.
Thank you, Professor Paul. Can I have my co-chairperson to interact with the audience and try to find out whether they have any questions? Dr. Yatu?
Am I audible there?
Yes.
You are.
Hello.
Yes, yes, you are audible.
Okay. It's my proud privilege to be here on this webinar, and my good evening to all the viewers. It was a wonderful talk from Dr. Paul, and I'm not able to see the all the panelists is there in the screen. They're not coming, but I would just request any of them that if they have any question to ask it to Dr. Paul, because he's leaving, so they're most welcome to ask any questions, please. I'm not finding any question in the box also.
Yeah, there is
Thank
no
you.
question in the box.
You have any question to ask, please? Hello.
Any questions? I don't see there are any questions, but one question to Dr. Paul. When do you think that we will be able to eradicate HBV by the use of any of the new molecules? We have set up some targets. World Health Organization, INASL, everyone has put a target that the world will be free of HBV. What is your opinion?
I think we all were hoping that we will have a cure for hepatitis B. There were a number of people who were working on hepatitis C, doing the hepatitis B research, but with this COVID, many of the scientists focused their interest on COVID. So this is going to be delayed. But as you saw, there are a lot of promising molecules. Every national, international meeting, we see these promising molecules, but it doesn't advance much further into phase 2, phase 3. So I think it's a long way away. I think we are going to suppress the virus. As you saw in some of the slides, long-term treatment may reduce the integration, reduce the risk of liver cancer, but I don't think we are going to find a cure in the foreseeable future. I think
Dr. Paul,
what do you see the future of newer diagnostic tests which are coming for hepatitis B, like core antigen, HPV, RNA? Do you see them seeing the light in the day-to-day clinical practice?
None of those tests are commercially available now. Obviously the DNA, the genotype with the resistant profile, all those things are commercially available. The core antigen RNA are commercially only for research purposes in this country.
Dr. Paul, there is a young female, E positive chronic Hep B, and she had high viral load. She initially was treated with interferon and then with nukes, but she has never, her DNA is all suppressed, and E antigen continues to be positive, HBsAg continues to be positive. She wants to get married, and obviously all the time the question will be that how long she has to continue this treatment, and what's your call on this patient?
I think she had a liver biopsy, or she has evidence of chronic hepatitis C.
No, she's Hep C negative.
Is she the immune tolerant patient? Are you talking about is somebody with chronic hepatitis?
No, that was the other thing. I thought that I will go with that she had a biopsy somewhere which was reported as a chronic hepatitis, but we could never get hand on that report. But that's all what we are worried, and what we are now thinking same thing, whether this girl actually was an immune tolerant phase and she is yet not clearing. So what is your take on these patients?
I think
immune
this
tolerant
patient, this patient will probably need to stay lifelong treatment. The question is about pregnancy. Tenofovir is class B drug. I had few patients, I had few pharmacists who had the same problem, chronic hepatitis B. They wanted to get married. We looked at all the data, we presented the data. The risk to the infant is almost negligible, because we have, if you extrapolate the data from the HIV literature, tenofovir is quite safe. At least my recommendation would be for her to continue the treatment until she EAND convert, or ideally a functional cure. But then the question asks, is there a risk in the pregnancy? That is something you need to individualize. If the patient says there is no way I'm going to take any risk, then one may have to stop it for the first 2 trimesters. But I try not to do that. Most of my patients agreed to continue the treatment. So far, we haven't had any problems. So I would use tenofovir for this purpose because it has better track record than any other medication. So I would tell the patient in the long term, if you look at the risk benefit, continuing the treatment long term may be much better than trying it out, and she may get a relapse, and then you have to go back on the treatment. It disappoints the patient when there is a major relapse.
Thank you, Dr. Paul. I think the time is up. And
Dr. Tolwat, can I?
So I think we have to move on. We have to move on to the next session.
Thank you.
I think it is my pleasure to invite the moderator for the next session. And we have Professor Shalimar from All India Institute of Medical Sciences. May I request Shalimar to introduce his panelist, Dr. Shalimar?
Thank you, sir. And I'd like to thank Professor Kaushal for the kind invitation. And I've been told very categorically by him to finish on time because we've got the next speakers in line, and then we have to do that. So I have a privileged 4 panelists with me: Professor Virender Singh, Professor Krishnadas Devdas, Professor Ashish Kumar, and Professor Sunil Taneja. And so we got, I think all of them are online. So I think let's go ahead without wasting time. So the learning objectives which I have kept for this discussion, which we are going to have today, is 2 cases. One is taking cue from where Professor Tuluvat left, is the approach to a management of pregnant women with an hepatitis B virus infection. What are the things which we need to keep in mind? And second is a very interesting scenario of a patient, which each one of us is seeing is a person who comes to us and has stopped his medication in the lockdown, what we are really looking at in terms of his therapy. As we know, hepatitis B is an important cause of cirrhosis and hepatocellular carcinoma globally. And the WHO has set our goal straight. By 2030. We need to eliminate the new infections by 90% and 65% reduction in mortality. And before the universal vaccination of infants, which is now also implemented in our country, almost 40% neonates got infected, and almost 90% of them developed chronic infection. So coming to our case, she's a 26-year-old lady who's the first pregnancy, 20 weeks now. She has no risk factors. Her antenatal screening showed that she had HPE antigen positive. DNA was high, 10^7 almost international units per ml, and her liver functions were all normal. Ultrasound revealed that it was a normal liver. Portal vein was not dilated. There was no splenomegaly, and seeks your opinion regarding the management of her pregnancy, as she's been referred to you by her gynecologist. So coming to the first question, which I like to ask Professor Krishnadas Devdas out here is, what are the modes of transmission of hepatitis B when we are looking at from mother to child transmission, or when do you consider such patients for treatment?
Thank you. Good evening to you all. Theoretically, there are 3 possible routes of transmission of HPV from an infected mother to an infant. It could be transplacental, transmission of HPV in utero. It could be a natal transmission during delivery, or it could be in the postnatal transmission during care or through breast milk. If you think which is the most common form of transmission, it is a natal transmission, that is during delivery or just before that. Why do we say that? Because if you give immunoprophylaxis within 12 to 24 hours of birth, you can prevent almost 95% of transmission to the baby. So that means the transmission occurs just prior to giving the vaccine. However, some 9% of patients or babies get the infection even if they are given vaccination. So there has to be another route, and that is the transplacental route, that is inside the uterus. It could be transplacental if there is a break in the placenta, or if there is a placental infection and the transplacental transmission of HPV. The HPV DNA has been shown to exist in oocytes in infected females and sperms of HPV infected males. So there can be an infection at conception itself. And finally, there can be intrauterine transmission of HPV to the fetus, not from the maternal blood, but ascending from the vaginal secretions of the mother that contain the virus. And finally, you can have a postnatal transmission. So we should advise them to take good care of nipples while breastfeeding, ensuring proper latching on and allowing the nipples to dry before covering to avoid cracking or bleeding, and having in mind that HPV is commonly passed by blood-to-blood routes. So these are the methods.
Okay, I think that that's a very important point which you have raised. The other important things when we are looking at transmission for hepatitis B virus from mother to child is the E antigen status. And what studies have previously shown is, and what we know clearly, as the DNA values goes up, typically more than 10 power 5, or that's 5 logs, we're looking at a risk of transmission which increases with the increasing logs of hepatitis B DNA. And what's also important to remember is that if a patient has undergone some kind of procedure during pregnancy, your patient is at risk. So you need to be very careful when you're evaluating first patient. The reason why we're discussing this thing is because most of these patients are usually referred to a gynecologist. Gynecologists these days may not refer to you, or if they refer to you, you should know what are the points you need to keep, and you need to tell your gynecologist regarding this could be the possible ways in which the mother can transmit the virus to the baby. Okay, my next question now comes in to Professor Sunil Taneja. So we've heard some from Professor Krishnadas regarding the options. So what are the options available right now to prevent mother to child transmission?
Yeah, good evening, everyone. Am I audible?
Yes, you are. Please go ahead.
So, well, this is a very important question, and it always happens that you're sitting in your OPD and you get a pregnant lady who comes to you and says that I have been diagnosed with hepatitis B and my surface antigen test is positive, and what do I do? As Dr. Thulvat said, that you have to discuss with the family, sit down with the patient and tell them that this is hepatitis B and what are the treatment options and how do you diagnose and stage the disease. And then comes this next step, they would ask that what is the risk of transmission to my baby and how do I prevent this transmission? So the best way to prevent transmission from mother to baby is by dual prophylaxis, immunoprophylaxis. One is vaccination as well as giving immunoglobulin to the child at the time of birth. This is best what has been recommended. But then this reduces the transmission rate from 90 to 10%, and there is a breakthrough in 10 to 30% of infants who have mothers who have a high viral load, which is said to be around 10⁻⁶ or 7 and even above that. So what has been recommended now is that if you give them dual prophylaxis along with antiviral to the mother from 28 weeks of gestation till up to delivery of 4 to 12 weeks of delivery, then the risk of transmission comes down significantly. And the drug which has been recommended for the mother is tenofovir.
I think we'll come to the drug. So I think you've highlighted very important things, that we've got multiple options available, and you need to keep in mind that you need to advise these at the time when you're seeing your patient in the outpatient, because your gynecologist and your pediatrician and your neonatal ICU should know that they need to take care of these precautions. And unless you advise them, it's very important that each one of them has to keep in mind, we presume that these would be given, but unless you, even in big hospitals, it is always missed. So we need to keep that these are the available options, we need to use them. Okay, so now comes the next option is regarding the drug safety and in which drug. So let me ask Professor Singh regarding, sir, what do you use and what do you prescribe for your patients? And what do you tell them regarding the safety of these drugs?
Yeah, hi. Hello.
Sir, you're audible, sir. You're audible. Please go ahead.
Okay. So there are different drugs, the antiviral drugs. One is the pegylated interferon and the standard interferon that is not used nowadays, especially in the pregnancy. The other oral drugs are the lamivudine, adifovir, and then entecavir. Then these are the drugs which are the category C drugs, and the category B drugs are the tenofovir and the talbubidine. But talbubidine is a weak antiviral, so hardly anybody uses talbubidine. So the most common drug which is used in these patients with the pregnancy, especially for preventing the spread to the neonate, is the tenofovir and the The dose you already know. And this is started especially in the last trimester when the E antigen is positive and the HBV DNA load is quite high. In that situation, you start and then you continue this drug for about a month after the delivery. This is as per the ASLD guideline. Because after the delivery, if you stop the drug, then you have to follow these patients also, because sometimes there may be a flare because there is a rebound. So you'll have to very closely follow these patients and then look for any worsening.
Okay, I think that's so you've given very comprehensively regarding the management. Okay, so we know as what you have mentioned the drug safety, but we now also know that this is a interesting meta-analysis published this year that showed it included many randomized controlled trials and observational studies and has clearly shown the benefit of using antivirals in preventing the transmission from mother to child. An interesting study published in NEGM in 2018, which randomized patients into two. We've got predominant data coming regarding mother to child from the Chinese literature. And this was not from the Chinese literature, but from the Western literature, in which you had patients divided into two arms, one which received only Hep B and vaccine, and the other arm received, in addition to Hep B and vaccine, is tenofovir. What this showed is, yes, definitely there was a less number of patients, less number of babies were positive for HBs antigen when analyzed at the last follow-up, that is at 6 months, but it was not statistically significant, but still highlighting the fact that yes, antivirals definitely have a role. Interesting data, which Professor Tuluvat has also mentioned. We've talked about the various drug, but this is the new kid in the block. That's the TAF. What you should know is a small sample size study, 71 mothers, showing a significant reduction in their DNA. And when these babies were tested at 6 months after delivery, none of them had a positive HBs antigen. Their growths, including height, weight, and head circumference, were comparable to the national standards, no congenital defects, but a bit of flares occurred. So essentially showing that TAF, as we are getting more and more better regarding its use in and switching from tenofovir to TAF, probably this drug may also be safe in preventing mother to child. But we need more data and more long-term data regarding its any effect on the baby and other issues. So coming to
except
now,
that Salimar,
yeah, please go
except
ahead,
that
sir.
abstract which Dr. Tuluvat said,
Yes.
There is hardly any literature on the TAF.
Very
So-
correct, sir. So this is the first ASLD small sample size study, but showing that gives us an idea that because we're using more and more TAF, and this is going to happen. So we'll get more literature. We need to see how things go. But an important data which is really of use to the day-to-day management. So my next question comes to what we've really discussed also previously is what Professor Ashish would like to answer is, if this patient comes to you in your OPD, sir, so this has come to us at around 20 weeks of gestation. What time do you want to start him on antiviral drugs? So if we're planning to start tenofovir, when do you plan to start her?
So good evening. I thank the INASL for giving me the opportunity. Am I audible?
Yes, you are audible, sir. Go ahead.
So I'll give you 4 situations. So there are patients who are already on antiviral since before they became pregnant. So for those patients, we'll continue the drugs. However, we need to switch over to tenofovir if they were not on tenofovir, if they were on entecavir or any other drug. So that is one. Second, those patients who are diagnosed to be HBsAg positive during pregnancy and have clear-cut indications for antiviral therapy, for example, they are having cirrhosis or advanced fibrosis, then these patients may have to be started on antiviral tenofovir right from the beginning. But the third situation are those patients who are, although having indications for antiviral therapy, but they are not emergent indications, and their DNA levels are also not high. Their AST, ALT is marginally high. So then we can wait till the pregnancy get over. But the fourth situation which you have mentioned, that these patients, although they do not merit antiviral by themselves, but we need to reduce mother to child transmission, and their HBV DNA levels are high, then most of the studies have shown that we have to give antivirals only on the third trimester, that is beginning 24 weeks. So we do HBV DNA at the 24 weeks. If it is more than 10 to power 5, then we start the antiviral and then repeat the DNA after 4 weeks to see if there is at least 2 to 3 log decline in antiviral. So we'll have to start at 24 weeks of pregnancy.
Okay, so I think that's a very important point what you have made. I wanted to just share an interesting meta-analysis published this year. Predominantly what you say is that we've got data predominantly from China, though we've used these different drugs. Now, if you look at what you have already highlighted, pre-pregnancy versus pregnancy, we do not have data on starting antivirals in the first trimester versus second trimester, but interesting small sample size studies, comparison between second trimester versus third trimester, showing though the data in each of these studies is small in numbers with different, but when you look at the overall analysis, probably starting earlier may be benefited. But we need to see more larger sample size data and looking at its effect, outcomes, before we really start recommending these drugs to be used even more earlier, because starting earlier may lead to even more reduction in the DNA and probably hypothesizing the fact that then this leads to a better or a lower chance of a baby getting HBs antigen from the mother. Now, this patient is almost at the time of delivery. She's 37 weeks. Your gynecologist calls you and says, what do you want me to do? Do you want me to go ahead with a normal delivery, or do you want me to go ahead with a cesarean? So Dr. Krishnadas, can you let us know what would be your practice, or what are you going to advise to this patient?
Yeah. This is a common problem that we face because the gynecologists always have this confusion. And as we have seen before, the majority of transmission from mother to child occurs during the natal period. So this could be because of high maternal viremia, transfusion of the mother's blood to the fetus during labor contractions, infection after rupture of membranes, and direct contact of the fetus with infected secretions of blood from the maternal genital tract. So if you do an early cesarean section, a planned cesarean section can avoid this. There was a review on 4 RCTs involving 789 patients, and they found that the cesarean section before labor or before rupture of membranes could bring down the MTCT. But there was a lot of bias involved in this study, and all the recommendations, all the guidelines say that the mode of delivery should follow the usual obstetric indication. If there is an obstetric indication for cesarean section, go ahead and do a cesarean section. Otherwise, it is not recommended for the prevention of HPV transmission. However, another thing that I would ask the gynecologist to do is to go easy on the baby. So as far as the fetus is concerned, the procedures that break the skin or mucosal barrier should be avoided as much as possible, because this can produce increased chance of maternal to child transmission. One is vigorous suctioning of the newborn's airway at birth. This itself can produce mucosal damage and can result in the virus going in. An instrumental delivery, if obstetrically it is required, you should go about with it. Otherwise, as far as possible, avoid it. And standard precaution should continue when handling the newborn. Visible blood, mucus, or amniotic fluid on the surface of the neonate and the cord should be gently wiped off. And standard procedures for cord cutting should be followed. And all these infants should get immunoprophylaxis.
I think I would agree with what the comments you made. That is the practice what each one of us have been following. It's very important is that when such a question is asked, we need to tell it's the indications should be as per the indications for the fetus or the maternal, and you should not consider doing a cesarean just for prevention. But if you look at the data just this talks about a little bit. So what important thing, it's for postgraduate, looking through data, there would be meta-analysis, there would be individual studies showing you that, okay, possible, there is a bit of reduction within elective cesarean versus an emergency cesarean versus, or say an elective cesarean versus a normal vaginal delivery. But do keep in mind when you're going through these studies is the number of samples which have been looked at. There are so many cofactors which are going on. Some of the patients would have received different drugs, different immunoglobulins. So it's very difficult to teeter out. And unless we get head-to-head randomized control trials, which I believe probably would be really very difficult to get, and looking at the ethics aspect of it, I'm not sure whether we'll be able to really get a true answer based on a randomized control trial for this. But the available data suggests possible. The cesarean may be of benefit in reducing. So there would be certain situations like a patient comes to you who's not received any kind of antivirals and says, okay, then if you're being asked such as at that kind of a situation, you got a pregnant lady who's there to deliver with 10 power 7. Okay, possible literature suggests that there may be benefit in such a situation, but maternal indications, fetal indications for cesarean should be the major thing which we need to keep in mind. Now, the pediatrician is not far behind. She again calls you up as the baby is delivered. She wants to know is whether breastfeeding can be done or not. So what's your take on that?
Yeah, about the breastfeeding. Breastfeeding is very good for the baby. So unless the patient, the lady is on a antiviral, then breastfeeding should be started as early as possible. If the patient is on an antiviral, it may be better to postpone breastfeeding till the antiviral is gone.
Okay, I think I'll take on that is like, that is what is the important thing. Breastfeeding has to continue. That is what most guidelines would recommend. But data, if you look at these meta-analysis, was a surprise. Is like there is data to suggest that probably breastfeeding may be associated, but we should not take into account this. Breastfeeding is good, though in patients, you may find HBS antigen in breast milk. There is a bit of issue with the tenofovir's transmission in the breast milk, but important to know the amount of concentration which there's there in tenofovir is much less, and it's not contraindicated, and babies should be given breast milk, and then you should tell your pediatrician and the gynecologist that the mother can feed her baby without any issues. So coming back to now, and very important questions for in this particular case, we had started the drugs for preventing mother to transmission. Maybe Professor Virendra Singh, sir, would you like to, his answer is, when do you want to stop our antivirals?
Yeah, the antivirals are started in the last trimester and we continue for about a month after the delivery. And because there is a very high chance of the flare, and we will have to be careful, monitor the LFTs, and the chances of the flare are much more because there is a sudden fall of the cortisol levels after the delivery, and this is like a rebound. When we give the steroids in these patients with the hepatitis B, and when we stop the steroids, there may be a rebound. So naturally, the steroid levels cortisol levels are quite high during the delivery, during the pregnancy, and after the delivery, there is a situation like rebound. So we continue it at least for about a month.
Okay,
can I just add here that the concerns about tenofovir have been about the bone mineral density in infants, because there is a small risk of transmission of tenofovir to the infants. But recent studies have shown that there is no significant effect on growth, even if it is transmitted in the breast milk. So people have said that, okay, you can stop it at immediately after the delivery up to 4 weeks, but some of them still say that up to 12 weeks you should continue, because this is a time period when you have the maximum flares.
I think, thank you, Sunil, for adding that. Whether you continue, whether you stop the tenofovir prophylaxis at delivery or 4 to 8 weeks, there is no difference in the rates of transmission of HBS antigen to the mother. What sir also clearly mentioned is regarding your flares. So flares are there, mild flares, which is there, but yeah, we've got case reports, but it's not ample amount of data to suggest that it would be really leading to clinical decompensation. Fetus, you rightly said that tenofovir, there is data to suggest that at long term, whatever data is available doesn't cause much differences in the bone mineral density. So let's now coming back regarding is now we've got what does our society recommend regarding this? So maybe Professor Ashish can add to that.
Yeah, INASL had given 2 documents about where they have mentioned about the pregnancy and hepatitis B. One was published in 2018 where the recommendations was for general patients, and in 2019 it specifically for pregnancy and liver disease. So in both the recommendations are almost same. If there is a HBV positive lady of childbearing age, she should be counseled that if she becomes pregnancy, then what are the implications, what are the risks for mother to child transmission, and what are the safety of HPV drugs. Second point which is given is that HPV positive lady, if she plans to become pregnant, then her treatment needs to be discussed, whether she would like to start antiviral now or after pregnancy. But if she prefers to start before, then the preferred drug would be tenofovir. Then all pregnant women across India need to be screened for hepatitis B in the first trimester. This is a strong recommendation. And the patients should be started on tenofovir only on the third trimester if we need to stop the mother to child transmission if the DNA is high. And all those ladies who are already on antiviral, they should be switched to tenofovir as soon as they are detected to be pregnant. And then newborns who are born to HBeAg positive should receive HBig plus vaccine. However, if the HBeAg negative women, the role of HBig is not clear and only vaccine can be suffice, and breastfeeding is not contraindicated. And regarding stoppage of antiviral, even at birth it can be stopped, but usual recommendation is about 4 to 12 weeks.
Thank you for that. I think you've summed up all INASL. So I think the WHO documents also recommends the same. You got maternal indications, treat, otherwise use a combination of all these. So the case was she was started on tenofovir at 28 weeks. She had a normal delivery, was stopped at 12 weeks after delivery, no flares. Male baby received vaccination, and at last 18 months of follow-up, the HBs antigen was negative. So that's what the learning. So coming to our next case, I will be very brief on that, but it's a very important scenario which each one of us is facing. This is and I think so. This person is a 35-year-old male who just came last week to my outpatient, seen by our fellow, and he's E antigen negative. He's on tenofovir. LFTs were normal at the last follow-up. His HBs antigen still positive. DNA is negative persistently. And he said to me that he stopped drugs for 8 months. So I think we can have an open discussion out here is once you see this patient, what's your call on that? And I think Dr. Yattu raised this important point regarding a female patient. Now case is a male patient. He has now stopped his therapy. So what's your take? Maybe let me start with Professor Singh regarding his take on that.
Yeah. See, this is important whether this is E antigen positive or negative.
Sir, he's a E negative, sir.
Do we know it? Okay.
Yeah, E negative, sir.
E negative disease. The ideal, the stoppage rule is the absence of the HBsAg or the zero conversion from E antigen positive to negative and the antibody development and HBV DNA. But this patient is still HBsAg positive.
Correct.
This patient has already stopped treatment. So there is likely possibility of the rebound, but 8 months have passed and there's hardly any HBV DNA if this is a recent report. So I think we can wait for some more time and then follow this patient. Otherwise, many of these patients may develop a rebound and then there is a problem, but the 8 months period has passed and we may expect the surface antigen disappearance also in maybe next few years.
I think that's a very important point. Does any one of our panel members disagree with that, or?
No, I have a question. Whether these reports are recent or these were at the time when he was continuing on the drugs.
So this was, we have an LFT now, and DNA also presently is negative, which has been done only which he carried that. So it is negative.
So if the DNA is negative and LFT is also normal, then
yes,
probably, and the LSM is also very low. So there's no reason to restart the therapy, and we should just monitor these patients and see. And we'll treat these patients as a new patient.
Okay,
so
that's very correct. I think we're little running short of time, so I'll just run through an interesting data which is there, I think, which Professor Yattu also wanted to ask regarding that. So this study is a Toronto STOP study in which patients were randomized, both E positive, E negative, who had a negative DNA or very low DNA, were randomized into 2 arms. One is to stop, second is to continue. So those patients who stopped, as compared to those who didn't stop, 29% of these patients only had a DNA less than 2000 and normal ALT at 72 weeks of follow-up. A significant fraction, 47% of them had some kind of flares, which predominantly only transaminitis, no liver decompensation, 38% required retreatment. HBs antigen loss, only one in each of the two groups. Now, another study, which is the finite study, which randomized 44 patients, 21 into stopping, 21 into continuing. And what we look at, interesting study, interesting data out here, that HBs antigen loss at 144 weeks was 19% as compared to 0% in those who continued. So stopping probably has maybe have some benefit. Looking at this, a group of all studies which have looked at those patients who are including both E positive, E negative, both cirrhotics, predominantly non-cirrhotics, a little more than cirrhotic patients, good amount of follow-up of almost like 47 months to 66 months, showing a good amount of HBs antigen loss in these patients. So there could be a potential benefit, but do we know who is this subgroup? Or if you're stopping these drugs, we need to follow them up every 3 monthly. Flares can occur, seroreversions can occur, clinical decompensation can occur. And I would agree with Professor Ashish regarding that your indication for starting probably as per the guidelines also in such a patient and you stop remains the same as starting for a new patient. Even the guidelines, what Professor Singh alluded was HBs antigen loss. But over here in our case is this patient who has right now a DNA which is negative and which is and LFTs are normal. I think right now what we can do is to just follow him up and see how he's doing, and then take a call if his DNA comes up or he gets a flare with transaminitis. But important fact would be is to keep following up such patients. You cannot say I will not going to follow. We need to follow, but I think the guidelines also recommend, even the studies recommend, and what Professor Thuluvat also said, probably we might be gaining something in terms of HBs antigen loss. I think I'll stop out here and then maybe we can take some questions if we've got time.
One more thing about this patient, I would like to evaluate him for fatty liver and evaluate for metabolic syndrome and cardiovascular risk factors. Even though I agree with you regarding HPV because he is negative for HBDNA after 8 months, so probably falls into the 29% who may have not reactivate.
Correct.
Well, I think, are there any more questions from the panelists to Dr. Shalimar?
Dr. Shalimar, can I ask you something?
Yeah, please go ahead, sir.
When should you do the HBV DNA? When the patient comes to you, or should you wait for the third trimester?
I think that's a
supposing just give a case scenario. Supposing the patient comes to you, she is maybe 12 weeks pregnant, and you do the HPV DNA. HPV DNA is 10⁻⁹. So should you start the antivirals a bit early?
So I think that's what Professor Ashish gave us 4 clinical scenarios. Does the mother need? If the mother needs, you need to take care of it right away. You're not going to wait for just a transfer because that's an indication. Now, if the second question comes in, data suggests possibly in that kind of a scenario where you're targeting only mother to child transmission, probably giving early may be beneficial, but you need to keep an important point in mind, small sample size studies. Even at 28 weeks and giving immunoglobulins and vaccination to the baby is going to take care of all these transmissions, and you're going to have almost a zero transmission.
Dr. Shalimar, can I ask one question?
Please go ahead, if Dr. Kaushal permits.
Yeah, just one question. So the vaccination dose which has been used is the standard dose in all children. So some recommend that if you use higher dose, the immunogenicity will be more and the results will be better. What is your thought on that?
Yeah, possible. That could be, even some people are recommending 4 doses. So I think that needs to be seen. That needs to be seen. We need to have more data, but I think the available data suggests the standard ones with immunoglobulins and probably adding on. So that's a incremental approach by adding antivirals probably may help us in reducing the transmission rates to minimal.
And there was another interesting paper from the Chinese group in, I think it was in CGH. They say that even if the HPV DNA level is less than 5.3 log, if the patient has had an history of NPCT or a threatened abortion or a threatened premature labor, or there is an indication for invasive procedure, even if the HPV DNA level is lower, you should start on antiviral. What is the
Exactly, I would agree, and I would make a last comment. If you got a first child who's positive with HBs antigen, any viral load of HPV in the mother, I would be starting. So with that, I'd like to conclude out here and hand over to Dr. Kaushal to move forward.
I think we as members of INASL would like to thank Kaushal Madan and his team for this wonderful meeting, and all the panelists and the co-chairperson and the moderator, Dr. Shalimar. I think we had a wonderful time with Paul Tulawat and other members of our team from India. Thank you very much.
Thank you.
Thank you so much, sir.
Kaushal.
Thank you. So we now move on to the last session of our conference, which is on alcohol, liver failure, and its complications. And to chair this session, I would like to invite Professor R.K. Dhiman, who's currently the director of SGPGI Lucknow. He was earlier the head of Department of Hepatology at PGI Chandigarh, and is also the editor-in-chief of the official journal of INASL, that is Journal of Clinical and Experimental Hepatology. And you saw him yesterday present his 10 years journey as the editor-in-chief of JCEH. Welcome, Professor Dhiman. We have Dr. Sandeep Sidhu, who's a senior consultant gastroenterology and hepatology at Sadhguru Pratap Singh Hospital in Ludhiana. And he's an expert in alcoholic liver disease with many publications. And we have Dr. Manas Kumar Panigrahi, who's the associate professor in Department of Gastroenterology at Bhubaneswar. So over to you, Dr. Dhiman, to take the proceedings forward.
Thank you, Dr. Kaushal, for the invitation. And the conference is going very well. And it is very much informative also. Without wasting time, I would invite my friend Dr. Ashwani Singhal to give a talk on non-transplant options for the acute alcoholic hepatitis, present and the future. Dr. Ashwani, please.
Thank you, Dr. Dhiman, for that introduction, and INASL for the opportunity to speak at this annual meeting. So let me share my slides. Are these visible?
Yes.
Yeah, it is visible.
It's fine.
Okay.
Now.
So here are my disclosures, and none of them is related to the presentation today. So over the next 15 to 20 minutes, we will talk about alcoholic hepatitis, what are the current available options. And then we will talk about the future and why we need to look into the future. And then finally, we will wrap up how best we can manage this disease in the present scenario. So we know that alcoholic hepatitis has a high short-term mortality, not only severe disease, but also almost 10% mortality in a short period of about 1 month in patients who have moderate disease with a discriminant function of less than 32, as you can see on this slide. So when you talk about diagnosing alcoholic hepatitis in a patient with decompensated ALD, typically NIAAA, as we all know, has given this criteria for clinical diagnosis of alcoholic hepatitis, as you can see here. And whenever the clinical diagnosis is uncertain, it is recommended to do a transjugular liver biopsy to make a definite diagnosis of alcoholic hepatitis. And what you see on the liver biopsy is a lobular inflammation, predominantly by neutrophils, accompanied by severe ballooning degeneration, ballooning of the cells, and Mallory-Hyland. And a typical, although not seen in all the patients, but in quite often in patients with more severe disease, is a chicken wire fibrotic appearance of the liver with pericellular fibrosis, leading to severe portal hypertension. And once we have made a diagnosis of alcoholic hepatitis, we know that we have to stratify the disease severity. Although there are a lot of scores, as you can see in this table, Typically, we use discriminant function index in a modified fashion, and when it is 32 or more, or a MELD score of 20 or more, to make a diagnosis of severe disease. So let me put together the summary of this section. Among patients who have decompensated ALD, we use clinical criteria for making diagnosis of AH. And whenever there is a diagnostic uncertainty, clinically we use transjugular liver biopsy and then stratify disease severity based on MDF or MELD score. So moving on to the treatment, and the nutrition plays a major role in this disease, irrespective of the disease severity. And I think the best observation data on this, we all know, came from almost 4 decades ago, a study published from Veteran Hospital, where you see almost negligible mortality in these patients when they were eating more than 3,000 calories to almost 100%, and the intake was less than 1,000 calories per day. And somewhat similar data were shown in a randomized clinical trial almost 5 years ago published. And although the 6-month mortality was no different between supplemented patients but versus non-supplemented patients nutrition-wise, but when the overall study population was stratified to less than 20 kilocalorie per kg per day, there was significant difference in mortality. People who are taking less than 20 kilocalories per kg per day. So I think the message of this study, of both the studies, I would say, and this came in form of a recommendation that patients who are unable to intake about 1,000 to 1,200 calories a day, they should be identified for nutritional supplementation, because this can translate into a better survival. Now, moving on to pharmacotherapy, and we all know, and this is one of the network meta-analysis published 4 or 5 years ago, including the STOPA study, the largest clinical trial in alcoholic hepatitis. And you see the mortality difference in treated versus untreated patients with corticosteroids was almost 50%. However, this was only lasting for about a month, and there was no difference in medium to long-term mortality, and pentoxifylline has no benefit. But we all know that corticosteroid is a suboptimal treatment option, and here I'm giving an example of, say, for example, we start with 100 patients with severe alcoholic hepatitis, meeting the definition, and almost 40% would be ineligible for steroids due to many of the contraindications, typically infection. And of the 60 patients out of 100 who are eligible to receive steroids, only 40 would respond to steroids, and their shorter survival will be almost, you can say, 90 to 100%. And this is further, another complexity is added by provider heterogeneity, that all physicians and all centers do not use steroids even in their eligible population. So this 40 may even translate to 30 or 20 patients in routine practice. So you can see, starting with 100 patients who are giving benefit to almost 20 to 30% of the population, clearly a very, very suboptimal treatment. And one of the reasons also is that steroid-treated patients especially are susceptible to infections and complications, especially in non-responders, because infections in alcoholic hepatitis are very common, not only at baseline, but also when they follow treatment with corticosteroids, the risk increases. Once you start the patient on steroids, you assess the treatment response at day 7 and sometimes at day 4 if you want to, by determining what is called the LIL score. And if the LIL score is below 0.45, they are responders, and it is recommended to continue treatment. But if they are non-responders, there is no benefit in continuing treatment after day 7, and you should stop treatment at day 7 because there is no further benefit from the treatment. So let me summarize the current scenario of the treatment. Patients with severe alcoholic hepatitis should be hospitalized for infectious screening at baseline and determining eligibility for steroids. If you find that they are eligible for steroids, they should be given steroids and determine LIL score at day 7. And responders should continue the treatment. Otherwise, you should stop treatment. And pentoxifylline has no role. And there should be patients who are severely malnourished and reduced intake should be recognized for nutritional supplementation. Now, moving on to the future, you clearly saw the need for looking into the future because we don't have many options to treat this disease. And here is the cartoon of the pathogenesis of this disease, where the disease starts also in the gut, liver axis, where there is lipopolysaccharide from the bacterial translocation, activating the toll-like 4 receptors in the macrophages and stimulating inflammation. And the hepatocyte inflammation is also mediated by direct effect of alcohol through its metabolism to acetaldehyde, and in mediation causes oxidative stress and release of reactive oxygen species. And the inflammation driven by either of the ways causes apoptosis of the hepatocytes, releasing a lot of damage associated molecular pattern, which further produce vicious cycle through the toll-like 4 receptors. And there's also release of other pro-inflammatory signaling, not only through cytokines, but also through recruitment of neutrophils and also extracellular vesicles. And these all cross-talk with the hepatic stellate cell causing fibrosis and the endothelial cells of the hepatic sinusoids causing portal hypertension. And therefore, you can see there are many areas where you can intervene, for example, at the gut-liver axis, the inflammatory pathway for apoptosis, oxidative stress, and hepatic regeneration. And I'll show you some of the exciting data which we have so far, although none of them is approved for use in clinical practice, but there is some promising results. For example, fecal microbiota transplantation. You see this open pilot study published almost 4 years ago from ILPS, where there were exciting results in about 18 patients, not only in improvement of the liver disease MELD score, but also survival. And this was compared to the historic control patients. And this is the latest study from VCU, from Just Bajaj group, where they have shown not only FMT in alcoholic hepatitis patients, and these were all moderate alcoholic hepatitis patients, was useful in a pilot study on 20 patients in a randomized fashion. 10 received FMT, 10 did not receive FMT. There was improvement in liver disease, but surprisingly and importantly, the FMT patients also helped the craving part of the alcohol, as you can see here by their ACQ or craving score, but also their psychometric analysis. And this was associated with improvement in alpha diversity as expected with the fecal microbiota transplantation. And this resulted also in improvement of the inflammatory signaling and reduced in cytokines in these patients. So there are a multitude of benefits from FMT, not only on the disease of liver, but also on the disease of the brain of alcoholism and alcohol use disorder. Moving on to the anti-inflammatory pathway, which is interleukin-1 receptor antagonist, or anakinra, and this is the phase 2 study on about 100 patients in a randomized controlled fashion. Although the 1 month survival was no different, but the primary endpoint, which was 6 months survival in this patient, there was a tendency in treated patients with anakinra. And based on these data, the drug is currently in phase 3, and the results are expected. Unfortunately, the Ceylon-30 or anti-apoptotic inhibitor AST1 antagonist was a negative study. The 2 months was the primary endpoint on survival, and the drug failed to reach that in a phase 2 study on about 100 patients, as we did in anakinra. But there is some light at the end of the tunnel, and this is an exciting molecule, DUR928, which is a very complex molecule, an epigenetic regulator. It downregulates the genes of inflammation and upregulates the genes of regeneration, causing beneficial effects. And in this pilot study on about 18 patients, predominantly severe disease, as you can see, look at the Lille score in this population, 0.1 to 0.2. That's the median Lille score. And compared to the average Lille score in steroid-treated patients, which is about 0.5. So predominantly, very useful effect of DUR928. There was 100% survival in treated patients at 28 days, which has never been shown in any trial in the past. and there was no adverse effects. So now this is entering into phase 2, phase 3 large study to examine the similar benefits of this molecule in larger population. Similar kind of data was shown by a regenerative molecule, interleukin 22, which was a phase 2A study in a dose escalating fashion. And as you can see, 18 patients here, safe trial, 83% responders compared to 56 in a prospective study. This study also mechanistically showed decrease in extracellular vesicle count and markers of inflammation and improvement in markers of regeneration. So something similar to the DOR28, and I think these two molecules are watch out for in the next few years. We have seen some exciting data on GCSF in alcoholic hepatitis from India. However, this remains controversial because two studies from Europe, as you see in the bottom C panel, they were failures on the use of GCSF in the treatment of alcoholic hepatitis. However, this meta-analysis in which we were part of was a benefit in the overall population, but when you stratify to Asian studies, which was a huge benefit, for the European population, there was no benefit at all. So summarizing the future, clinical trials with newer targets are in progress, and we have seen many. There are modified trial designs. I think that is important because we are now including even moderate alcoholic hepatitis patients. Our endpoints are a little more out at 3 to 6 months, and we are using emerging biomarkers, as you saw in interleukin 22 trial, that we are using as markers of mechanistic proof of evidence, but also as markers for following up these patients in practice. FMT, GCSF, interleukin 22, and DOR928 seem promising, and we watch out for their phase 3 studies in terms of what this data show. Now, moving on to the last section, that we know that in the current scenario, that we don't have many drugs, but what we know that abstinence is what matters in these patients, especially after they have recovered from an episode of alcoholic hepatitis. As you see in this prospective population, that even that group which was drinking moderate amount up to 30 grams per day, you can see 2.3-fold risk of dying over 4 to 5 years compared to completely abstinent patients. So one of the message from this slide is if they have to survive in the long run, complete abstinence should be achieved. And therefore, these patients, sooner than later, should be enrolled in an addiction program and identify those patients who would benefit from integrated model with addiction medicine. Screen these patients for alcohol use disorder using the identification test or audit. This is a very comprehensive 10-item questionnaire. As you can see, each self-reported by the patient from 0 to 4, a total score of 40. However, a shorter version with the first 3 scores can screen those populations which have alcohol use disorder. And I'll show you later how we do that in the end of the slide, in the end of the presentation, how we use this questionnaire on audit score in selecting the population who would benefit the most from the integrated model. But how the addiction medicine would help, we know that behavioral therapy helps, whether we do it cognitive behavioral way or motivational way. But pharmacotherapy, which is one way of treating these patients, and here we have highlighted some of the FDA-approved medications, acamprosate, disulfiram, and naltrexone. None of them is tried in liver disease, and that's the problem. Of the non-FDA-approved medications, I think 2 are highlighted here. Baclofen, which is endorsed by the ACG as well as the ASLD for use in liver disease patients, although non-FDA approved, but this has shown to be safe in this population. And gabapentin has been shown to be safe and is endorsed by APA or American Psychiatry Association for use in liver disease patients. So my personal choice and recommendation would be if you have to use liver disease population for treatment of their alcoholism, baclofen and gabapentin are probably safer in this population. So summarizing this part, alcohol consumption is the strongest determinant of disease progression. Among ALD patients, baclofen is effective and safe, and behavioral therapy are useful. An integrated care model with multidisciplinary teams should be promoted in this population to recognize those who would benefit the most with this model. And before I close, I would come back to how we can best treat this population as we see today. So we have to be realistic and hopeful for the future. So we know that the first is to make a diagnosis. We talked about it. Then to determine the eligibility for severe disease and eligibility for steroids. Then how we follow these patients on steroid therapy and decide who would continue, and finally eligibility for transplantation, those who do not respond to treatment or who are ineligible for steroid therapy. And I think this is one way we can improve the outcome of these patients, and that right from the beginning we identify these patients and try to integrate them the multidisciplinary care with addiction team, recognizing their alcohol use disorder as the second pathology, not only focusing on liver disease, but also their alcoholism as a dual pathology. And this is how you can use the audit brief question. So a total score of 12 of the first 3 questions. If the score is 4 or more in males and 3 or more in women, then you do a full audit questionnaire. And if the score is up to 20, you can deal yourself with a brief intervention. But if the score is more than 20, these are the patients you want to enroll with behavioral or pharmacological therapy with addiction medicine, because they have a moderate to severe alcohol use disorder. And these patients would benefit the most with an integrated fashion and treating them with a multidisciplinary team. So I hope I have given you both the present, the future, and the realistic situation of this sick population, which is very difficult to treat, as we all know. I would stop here. Hopefully, I have not extended my time, and I'll be happy to take questions.
Thank you, Dr. Ashwani. It was a very good and a very crisp talk. We can have the couple of the questions. Dr. Kaushal, can we have now or at the end of the all presentations?
At the end of the third session, sir. Third presentation.
Okay. Now we can move on to the second talk. That is the infections in the cirrhosis, detection, relevance, and the management. And I request Professor Rajendra Reddy to give this talk. Dr. Reddy, please.
Okay. Thanks so much, everyone. Let me try and see if I can share my screen. Where is this? A second. Just share. All right, there you go. Can everyone see my screen?
So please swap presenter view.
Okay, where do I do this?
We can see. Second one, sir. Second one.
Second one, display settings?
Yes, yes. Yes, first one, sir.
Okay, got it. All right, thanks. All right, thanks very much, everyone. I've been listening to the talks and the discussion, really exciting and quite a passionate discussion. So I've been tasked with talking about infections and cirrhosis. I believe this is an evolving challenge, and quite a few patients present with infections that need special attention and consideration. So as an overview, if you look at bacterial infections and cirrhosis, they account for approximately a quarter of all deaths in cirrhosis. And in some places, in some parts of the world, it might be more. In other parts, it might be less. If we were to look at hospitalized patients, these infections are quite common, and in the background of cirrhosis, an infection can occur as is a nosocomial infection, and there's a several-fold increase in risk of nosocomial infection. Now, a few years back, almost a decade back, we kind of toyed with the term called decades. And in fact, we wrote a review and coined the term cirrhosis-associated immune dysfunction, which actually is a true representation of the events that go on in patients with cirrhosis. There's several permutations in a given patient with cirrhosis that highlight the immune dysfunction that exists in them. There are qualitative and quantitative abnormalities. If you look at neutrophils, you look at monocytes, macrophages, lymphocytes, there are several qualitative abnormalities that you can see. And then these patients also have hypoproteinemia, they have decreased opsonization, decreased complement levels, etc. And malnutrition and sarcopenia, as we recognize, are not uncommon in these patients. We had Ashwini give an elegant talk on treatment of alcoholic hepatitis, and in as much as there is enthusiasm for corticosteroids, I must admit that that is one drug I dread in these patients. So interesting that in the community they tend to forget about the 7-day reassessment rule, and they are corticosteroids for a long period of time. These patients have a variety of infections, including fungal infections. And then, of course, we used interferon a lot, and that itself set them up for infections. But fortunately, we have DAAs. Apart from a state of immune dysfunction in these patients, there are also several events that evolve at the gut level that facilitate bacterial translocation. Apart from enhanced bacterial translocation, there are luminal factors that facilitate bacterial overgrowth. There might be impaired attachment to immunoglobulins, the bacteria. There is penetration, and there is impairment of a local immune response. So all of these play a role in a bacterial translocation, which readily facilitates portal bacteremia and in consequences. Now, we recognize that patients with develop sepsis, there are several events that evolve, such as endotoxemia, increased nitric oxide, there might be a cytokine storm, there's an exacerbation of pre-existing vasodilation, which leads to decreased organ perfusion. The net result is multi-organ failure. You can have acute renal failure, circulatory failure, etc. Now, we'll touch upon acute and chronic liver failure. In the Western world, it's often infection-precipitated acute and chronic liver failure. I know based on a PASL definition, infection-related liver failure is not something that is categorized as acute and chronic liver failure, although infections are believed to subsequently lead to high mortality. So with the increasing number of organ failures, we recognize that there is a linearly increasing mortality risk. The more common infections, just to kind of complete the circle, are of spontaneous bacterial peritonitis, UTIs, pneumonia, and spontaneous bacteremia, which is not uncommon in these patients. And if you were to look at specific bacterial infections and cirrhosis, you have patients who are susceptible to Vibrio species, Aeromonas, Yersinia, Listeria, Campylobacter, etc. So there are common gram-negative and gram-positive organisms, while there are uncommon specific bacterial infections that you can see in patients with cirrhosis. Now, I'd like to give you a little bit of a Western perspective on the kind of infections we see in hospitalized patients with cirrhosis. During the discussion, I hope there was a discussion on what kinds of infections are seen in India. I know there is a higher prevalence of multi-drug resistant organisms there. It's very variable. It's somewhat geographic specific in a sense. So let's just at least have me present the kinds of infections we see in hospitalized patients with cirrhosis in the Western world. To that end, we do have a consortium called INASL. Some of you may be familiar with this. This has been going on for about a decade, where we collect data on patients with varying degrees of severity in cirrhosis. When we first explored the question of infections in our cirrhotic cohort, this is what we found, in that 20% had spontaneous bacteremia, about 23% had SBP, UTI was common, and there are other infections that variably contributed to the infections. And if we looked at bacteria, about a third of them were gram-positive, and 28% were gram-negative. What is important is in that 30% of patients, there was no growth while they exhibited sepsis physiology. If you look at community-acquired versus healthcare-acquired versus nosocomial infection, more often the community-acquired infections are spontaneous bacterial peritonitis and UTI. But then you were to look at healthcare-associated, in essence, healthcare-associated infections are defined as infections in those who had a hospital contact within the previous 6 months. You saw spontaneous bacteremia and then skin infections. And then, more importantly, when you look at nosocomial infections, there's UTI, respiratory infections, and C. diff, all potentially preventable infections in hospitalized patients. So there is work to be done to try and prevent nosocomial infections that are potentially preventable. And if you were to look at first and second infections more often were, again, respiratory, C. diff, and fungal infections. And if we were to look at mortality was more often in patients with spontaneous bacterial peritonitis, respiratory infections, and C. diff, and to a lesser extent in those cutaneous. I'm sorry, it's a spontaneous bacteremia, I apologize, and a higher mortality as opposed to spontaneous bacterial peritonitis and skin infections and UTIs. Now, antibiotic prophylaxis in cirrhosis, we have secondary prophylaxis for spontaneous bacterial peritonitis with norfloxacin or ciprofloxacin. For primary spontaneous bacterial prophylaxis, we do use these antibiotics, but in select patients with extremely low protein ascites. Along with that, I would add some degree of renal insufficiency and elevated bilirubin. And then for GI bleeding, we do use antibiotic prophylaxis as well to prevent infections. Now, if you were to look at antibiotic prophylaxis, there's good and bad. With antibiotics, there's a low risk of gram-negative infections, but there's a high risk of multi-drug resistant organisms and gram-positive organisms evolve. So one has to really be careful and restrict the use of these antibiotics and confine to carefully selected situations. And this is still experimental, whether you consider non-antibiotic prophylaxis is a question that needs to be studied extensively. Now, early antibiotics are on demand. So traditional infectious diseases principles say, well, we should wait till we have some evidence of an infection and not just go by certain hemodynamic changes, for instance, or SIRS criteria. But in patients with cirrhosis, I think it really makes a big difference in terms of early intervention versus waiting till they have obvious proven culture-proven infection. And here is some data on timing of effective antimicrobial therapy and impact on survival. And if you were to look at time in hours on the x-axis, and the earlier the antibiotics are started on the y-axis of the odds ratio of death, the lower the mortality. And really delay antibiotic, you have a high mortality in these patients. And if you were to look at, again, 0 to 3 hours versus 3 to 6 hours and later on, clearly the ones who have antibiotics started after onset of shock, they have lower mortality compared to those in those where there's a delay in instituting antibiotics. Now, Jazz, Patrick, and I are in the process of writing a review for a major journal, and we kind of came up with this algorithm of management of patients with cirrhosis and suspected infection. So if you have any of the following criteria of low MAP, elevated lactate, low oxygen saturation, tachycardia or severe bradycardia, tachypnea, or there is a depressed respiratory system, persistent decrease in level of consciousness. We transfer them to ICU. A set of investigations that we all are familiar with. Then we want to treat them with the more broader antibiotic spectrum of vancomycin and meropenem. Obviously, the general measures, fluid resuscitation within 3 hours, therapeutic paracentesis, aspiration precautions, DVT prophylaxis, stress ulcer prophylaxis. Then they have low MAPs, pressors, and if the MAP is low, despite pressors, use hydrocortisone. And then if they don't meet any of the following criteria that indicate a certain degree of sickness, you can treat them on the floor, and there is an algorithm for assessing for spontaneous bacterial peritonitis, pneumonia, urinary tract infection, C. diff infection, and bloodstream infection. And then there's antibiotic regimen for each of these situations, and a follow-up is recommended as well. So if one were to have this algorithm in place, particularly if you have medical residents or fellows, you're unlikely to miss any step in proper assessment and management. Albumin. It's beyond the scope of my talk, but I just want to mention about albumin because it does have several functions. It obviously increases oncotic pressure, may have antioxidant properties, so it might stabilize the endothelium, may have immunomodulatory properties. It's in the context of infection. The well-quoted studies from the Spanish group where they showed that albumin on day 1 and day 3, along with antibiotics, decreased the rate of renal failure in patients with spontaneous bacterial peritonitis, and also decreased in-house mortality and 3-month mortality. 3-month mortality went down from cefotaxime alone from 41% to 22%, and in hospital mortality also decreased. So this is a classic paper that has led us to change our guidance on a use of albumin in the context of spontaneous bacterial peritonitis. Now, ACLF, I just want to make a couple of comments. We know there's a unique form of decompensated cirrhosis. It's not acute liver failure, or and it's not just plain decompensated cirrhosis. It's been associated with high mortality, and we have these various definitions. But what is fundamental to each of these definitions is that there is organ failure, be it the NACSL definition or Easel-Cliff definition, or PASL definition. Organ failure is critical, and with the increasing number of organ failures, there is a linearly increasing mortality rate. And this is important because we certainly invoke the futility role, and we discuss goals of care. I know it's challenging in certain countries to withdraw treatment. There are all kinds of pressures from family, etc. But we are very upfront and based on our experience with organ failures in the ICU, we initiate goals of care much early on. And here you can see our experience. This is something that we published from INASL, where we had patients with cirrhosis over a 2-year period, and about 136 patients were listed for liver transplantation. And within 6 months, there was a high delisting rate, actually about 40%, 42% were delisted or dead within 6 months of infection. I'm sorry, not listing, 6 months of infection. So what it tells you is that, at least in our experience, the major reason for delisting or death in the transplant population is infection-related multi-organ failure. It is not progression of hepatocellular carcinoma. It's not comorbid conditions such as cardiovascular disease. It is infection-related multi-organ failure that often leads to delisting in our liver transplant population. Lastly, I want to touch upon the new kid on the block, COVID-19 in the liver. I think there are certain important aspects of this in the context of underlying chronic liver disease or independent of underlying chronic liver disease. You can see abnormal liver tests. We all recognize there's a functional receptor for SARS-CoV-2, which is the angiotensin converting enzyme 2. It's present in biliary and liver epithelial cells. There's just a report that was presented at AASLD on cholestatic manifestation of SARS-CoV-2, suggesting that there's a direct infection of the liver, but generally it's not panned out. You often see subtle abnormalities in transaminase in a good number of patients, and there have been rare cases of severe acute hepatitis described in patients with COVID-19. So, what are the effects of SARS-CoV-2 on the liver? Is it a direct viral pathogen? Is there an inflammatory immune response? Some patients have very high ASTs, that are myositis or cardiac ischemia, and they believe that it's a liver related AST elevation when it might actually be from myositis or cardiac ischemia. There's tremendous opportunity for drug hepatotoxicity, and there might be other reasons as well. The provocative paper is from China, where they raised the question of whether this virus is an innocent bystander or actually hepatic pathogen. They had 156 COVID-19 cases, and about 40% had abnormal transaminases. And what and this was published in JHEP, so it had to go through a vigorous review. And what they've shown is in the middle part on a HNE stain, they've shown that the patients had apoptosis and binucleated hepatocytes, and then using immunofluorescence, they found certain CD4 cells to be present in these hepatocytes that may have been a response to SARS-CoV-2 infection. Last but not least, and importantly, on electron microscopy, they point to some findings, observations that they suggest are particles of SARS-CoV-2. So this begs the question, is there potentially a direct infection of the liver possible from this virus? Now, what about outcomes in patients with advanced liver disease and COVID-19? This is the earlier paper from Italy, where they noted a 30-day mortality rate of 34%. And then if you were to look at mortality breakdown, about 25% were COVID-19 related deaths, and about 12% were liver-related deaths. So more of COVID-19 related deaths as compared to liver-related deaths over a 30-day period in patients with cirrhosis. Now, we did a study as well that we published, and this was the kind of study that I thought would be the right way to do it. So, in the sense that most studies talk about cohorts of patients with cirrhosis with no comparators of patients without cirrhosis. So here, over a period of time, from 7 centers, we took in patients with cirrhosis, those with and without COVID-19, and then also use a contemporaneous cohort of COVID-19 patients without liver disease. So we had 127 patients with cirrhosis without COVID and 108 patients who are COVID-19 positive. I'm sorry, 127, right, 108 patients COVID-19 positive without cirrhosis. And then we matched them let me go this again. I'm sorry about this. We had 37 patients with COVID-19 and cirrhosis. That's the important thing. And 127 patients with cirrhosis, no COVID-19. So 37 COVID-19 cirrhosis, 127 cirrhosis, no COVID-19. And then we matched them 1 to 2 to 1 to 5 by age and gender by each side, patients who had COVID-19 without underlying liver disease. And the bottom line is patients with cirrhosis with or without COVID-19 had a higher mortality than those who had COVID-19 alone without any underlying liver disease. But then what is important is that in the cirrhotics, with or without COVID-19, the mortality was similar. So what this states is that just because you have COVID-19 in the background of cirrhosis, you're not likely to have higher mortality. These patients, ones who had COVID-19 in the background of cirrhosis, died of COVID-19 complications, where those with cirrhosis alone died of cirrhosis complications. So there was a high mortality due to another reason, something we need to keep in mind. And similarly, in transplant, you'll see reports out there of cohorts of patients with who had undergone liver transplant have high mortality. But this was the nicest study done, published in Lancet Infectious Diseases, or Lancet Gastroenterology and Hepatology, from a secure cirrhosis website where cases are submitted. They used a contemporaneous comparison cohort. So it's 151 liver transplant recipients. There was a contemporaneous comparison cohort of non-liver transplant recipients, almost 4-to-1 ratio. You looked at hospitalization, liver transplant, and contemporaneous cohort, no difference. Requirement for intensive care, no difference. ICU admission, a little higher in liver transplant recipients. Invasive ventilation, a little higher in liver transplant recipients. But more importantly, no difference in mortality. It's actually confounders such as increasing age and comorbidities such as increased creatinine and non-liver cancer that were responsible for death, and liver transplant was not independently associated with death. And you can see here, mortality was 28% in liver transplant recipients versus 27% in the comparison cohort. So we have really no reason to believe that liver transplant recipients are a unique population that is susceptible for severe COVID-19 and does a higher mortality. And this is the kind of study we need to do to have a nice comparator to get a sense of what might be the risk in the quote-unquote high-risk population. So to summarize, cirrhosis is an immune dysfunction state. The spectrum of infections are not uncommon in patients with cirrhosis. There's high morbidity and mortality. ACLF and multi-organ failure readily evolve, and we see a high morbidity and mortality. and SARS-CoV-2 is the new infection that can impact outcomes in patients with cirrhosis. Thanks very much, and I will wait for the question and answer period.
Thank you, Dr. Reddy, for a very informative talk. Now I may request Dr. Sidhu, who has just logged in also, to introduce the third speaker, and then Dr. Manas to initiate the discussion also. Thank you. Dr. Sidhu, please take over. Dr. Sidhu? Dr. Manas? Any one of you?
Dr. Manas, please continue.
Yes, good evening all. And the third presentation by Dr. Praveen Sharma from Sir Gangaram Hospital is on minimal hepatic encephalopathy, why and how in the clinics. Please, Dr. Sharma.
Okay. Thank you, Dr. Kaushal and the INASL team for giving me a talk on minimal hepatic encephalopathy, why and how in clinics. So this is the last topic for today's discussion. So minimal hepatic encephalopathy, the prevalence is about 25 to 75% in cirrhosis, depending upon the method which is used for the diagnosis and the stage of liver disease. So the question for us is why it should be screened. The second is which patient needs screening, and the third, how it should be done in clinics. So we classically know patient with cirrhosis can have a normal cognitive function. They may have a minimal hepatic encephalopathy and the overt encephalopathy, which is from grade 1 to grade 4 according to West Haven criteria. But we all know that in clinical practice and in clinics, it is very difficult to differentiate between minimal hepatic encephalopathy and the grade 1. So a new classification has come up which has categorized encephalopathy into unimpaired cognitive functions, either covert, which is a mixture of minimal and grade 1, and the overt, which can be easily diagnosed in clinics. So we are discussing about covert encephalopathy. So why it is important to diagnose minimal hepatic encephalopathy? First thing, because it is a leading cause of cognitive dysfunction in cirrhosis. It also causes impaired quality of life in all these patients. There is a high risk of development of overt encephalopathy. They have high risk of mortality. They have limited ability to operate complex machineries. They are unable to drive, and they have more accidents compared to cirrhosis who have no MHE. They have high prevalence of sleep disturbance. It is also a burden on the healthcare resources because these are the patients who require more care. These are the patients who develop more hepatic encephalopathy, and there are higher risk of falls. So these are the all components in patient of cirrhosis who have minimal hepatic encephalopathy. So patient of cirrhosis should undergo testing to diagnose minimal hepatic encephalopathy. There are various studies which have shown that even with the same MELD score, if the patient has minimal hepatic encephalopathy, so these are the patients who are more prone to develop increased mortality. That is, that their survival chances are less compared to those who have the same MELD score. So even if two patients have a MELD score of 15, one patient has a minimal hepatic encephalopathy, another doesn't have, then these are the patients who have MHE are more prone to die in the future. There is a meta-analysis which have shown that these are the patients who developed overt encephalopathy. These are the patients, if you have a child A cirrhosis and patient has MHE, these are the patients who developed faster for the decompensation stage comparing to those who do not have MHE. Their health-related quality of life, I already told that these are the patients who has poor quality of life in terms of both social interaction, their mobility, their work pressure, and other things. Sleep disturbances are also more common. And these are the patients who have more frequent falls. So these are patients prone to develop fractures. So these are cirrhosis patients should always be evaluated for minimal hepatic encephalopathy. If they are a driver, if they are a driver for public transport, then these are the patients who have a high risk of driving accidents. So one should always screen. One should always ask the nature of the job of these patients. So we have come to know why these patients should be screened, because we know patients who have cirrhosis with MHE, they have got poor survival, their rate of progression of cirrhosis is more, and these are the patients who develop more hepatic encephalopathy. So any patient of cirrhosis in your clinic, If you diagnose him as MHE, then these are the complications which probably he will develop in the future. We also know that the patient life, to make him more comfortable, he should have a sound sleep, he should be walking normally, his health-related quality of life should be good, and there should not be any problem with the driving. So the patient who have MHE, they have got the poor sleep pattern, they have a high chances of fall, so these patients should be evaluated. But if we diagnose MHE, does we have any option for the treatment? So we have treatment options also, because lactulose, rifaximin, probiotics, and the combination of these has shown to improve MHE. So if we diagnose this patient, we have treatment options also. Number of meta-analyses has shown that lactulose, rifaximin, probiotics improves minimal hepatic encephalopathy to a varying degree. Another important study, that rifaximin, which we normally give for the prophylaxis of secondary prophylaxis of HE, also improves MHE. And improvement of health-related quality of life is also seen if we treat patient of MHE. So what are the different tests in our clinics which we can go to diagnose MHE? Most of us know that MHE should be evaluated, but 99%, maybe 90%, they do not diagnose MHE because of major problems. The gold standard is fast battery test. It is considered as the gold standard, or the paper pencil test. We have number connection test A, B, the digit symbol test, the serial dotting test, and the line tracing test. A combination of these 5 tests are done, and the score is calculated to diagnose MHE. But the problem with this fast battery in clinics is that it takes about 20 to 30 minutes to cover all this, and we do not have normatives, because the normatives depends upon the age and the gender and the education status. So people who do not have normatives, then we cannot diagnose the phase battery, the MHE according to phase battery test. Then we have some computerized tests. The important one are the ICT inhibitory control test. But we all know that most of us, they do not have computer in our clinics, or the patients are not that computer savvy. And this test also requires about 30 to 40 minutes, which is not possible in the clinics. The other test is the Stoop app test. This is a simple test which we can download in our mobile, the Android or maybe the iPhone. And I think we can diagnose based on the instructions are there, and we can diagnose MHE in about 10 to 15 minutes at the maximum. So this is an important test which we can do in the clinic test. Another is a critical flicker frequency. It is a very bedside tool. Patient just had to wear this, and there is a button which need to press when he sees the light to be blinking. This is again a simple test which requires about 10 minutes or maybe less than that to diagnose critical flicker, to diagnose MHE. So this is an important test which can be done in clinics. Another is very simple, is animal naming test, in which you ask the patient to count the number of names of animals in just 1 minute. If he's able to do that, maybe more than 15, then it's okay. If it is less than 10 to 15, then patient has some impairment. This is a very simple test which has shown good sensitivity and specificity compared to the face, which is a gold standard. And it has also shown that people who have abnormal naming and test, if you follow this patient for a period of 6 months, these are the patients who developed overt encephalopathy. So what are the tests which we have, and which the test which we can do in the clinics is the FAST test. It is simple, though the gold standard, but the disadvantage is that we need a normatives, which is not available in majority of the countries. In India, we have normatives, but this test requires 10, 15. Then we have critical flicker frequency, which is a simple bedside test. This is a problem because too less, but the time period is about 10 minutes. We can do the Stoop test in our clinic because it is an app-based test. The time taken is about 10 minutes. It is a simple test which we can go. And the other important test is the animal naming test, which does not require any instrument. It's very simple, but it has to be validated in normatives. It has to be validated in your own population. And the time taken is just 1 minute. So these are the tests which I think can be done in the clinic, which is the animal naming test, the Stoop test, and the critical flicker frequency. Who should be tested? Ideally, all patients with cirrhosis should be tested, but people who are doing some professional jobs, like they are driving, they do some complex machinery technicians. So these are the patients one should always screen for MHE. If the patient has a history of repeated falls, sleep problems, smell problem, or recurrent HE, these are the patients should be screened. Cognitive changes as told by the relatives, or if the patient himself says that I am confused, my memory is getting poor, or I forget a lot. So these are the patients who should be screened for MHE. Patient with decline of work performance observed by the relatives or colleagues should be tested for MHE in your clinics. So to summarize, MHC should be evaluated in clinic, especially in a subset of patients, which I already told. It predicts survival and overt encephalopathy, so it should always be monitored in every patient of cirrhosis, especially with child B and C. It merits treatment. If you diagnose, then it should be treated. CFF, that is the critical frequency, animal naming test, Stroop test, and if you have the normatives, then the FES tests are the simple and reliable tests to diagnose MHC in clinics.
Thank you, Dr. Sharma, for the excellent presentation. So to start the question and answer, can I ask Dr. Singhal, sir?
Yes.
So is there any need to differentiate severe alcoholic hepatitis from ACLF, alcohol-related ACLF? Is there any need?
I think ACLF is a more severe form of alcoholic hepatitis. So I think the spectrum could be moderate alcoholic hepatitis and severe alcoholic hepatitis without ACLF and with ACLF. So it's, I think, a more severe kind of severe alcoholic hepatitis, more severe form.
How to differentiate them?
Well, I think the same application of ACLF criteria, whether you use for the INASL, CLIF classification, or Basel or NEXL, whichever classification you want to use, it would be the same, basically depending on the organ failure and the number of organ failure. Define ACLF and then the severity of ACLF population. But I think your question becomes relevant in terms of treating these patients with steroids. As this ACLF becomes more and more severe, they become exclusionary for steroid treatment. Patients with renal failure, patients with cardiopulmonary failure are now candidates for corticosteroid therapy, typically excluded from those kind of treatments. Maybe that may be more relevant.
Thank you, sir. Another question for you in the question and answer box. How to manage alcohol withdrawal in patient with alcohol-related decompensated cirrhosis?
Yeah, I think this is an important question. For the sake of time, I did not present that part in the discussion. Short answer, there's a SIVA protocol. We all know we follow these patients for the management of their alcohol withdrawal. If it is a mild to moderate alcohol withdrawal symptoms, I would say benzodiazepines, cautious use, short acting, lorazepam, ativan would be a standard treatment of choice. If it is more severe alcohol withdrawal, I would see propofol would be a very safe drug in these patients. I would avoid diazepam and more longer acting benzodiazepines.
So, thank you, sir, for the excellent talk and question answer. Can I ask Dr. Reddy? So, sir, what is your experience on spontaneous fungal peritonitis?
What's your experience? So generally, we don't see it apart from certain select situations, obviously. And one situation that I have seen it is in patients with alcoholic hepatitis. And then who've been on particularly prolonged courses of corticosteroids. And secondly, obviously, you can see it in our transplant patients. Well, it is obviously an ominous infection, and we need to treat it aggressively. In our experience, it's in less than 5% of our abdominal infections. It might be relatively more in other countries. We've been able to rescue them, but obviously there's a high rate of renal failure, other organ failure, and then mortality in these patients. But fortunately, it's relatively uncommon. Of course, you can also have not necessarily peritonitis, but obviously if during paracentesis you nick the bowel, you can see contamination and peritonitis there as well. So that's been my experience in this part of the world.
Sir, who are the patient? Whom should we screen for this fungal infection? Which group of patient? What are the characteristic? Which group of cirrhotic patient, decompensated cirrhotic patient, we should screen for fungal infection?
Again, fungal peritonitis you're talking about.
Yeah.
Again, in my experience, it is primarily I have been in these two cohorts of patients that I talked about: severe alcoholic hepatitis and liver disease and ascites, particularly in those who've been on chronic, well, relatively longer than necessary corticosteroid therapy.
So Dr. Chauhan is asking, what is the role of albumin in patient with other infection other than SBP, spontaneous bacterial peritonitis?
While theoretically there are some great function that albumin has, it's not been looked at in the context of other infections. What is known is that in patients who have infections, systemic infections, they are prone to have renal failure, acute kidney injury. And in that case, given a situation in these patients with cirrhosis where there are hemodynamic abnormalities with peripheral splanchnic vasodilation, peripheral vasodilation, and decrease in effective arterial blood volume, potentially there could be a benefit with albumin in increasing intravascular volume and mitigating the renal complications that might be seen in infection. But whether it has an additive benefit in treating an infection is not known. So it's primarily, if we were to use the albumin, it would be in the context of evolving AKI.
Dr. Singhal, this is Dr.
Yes.
Sidhu.
Yes, Sidhu.
I have a simple question for you, sir. While steroids are obviously the mainstay of treatment in the West, in our country and in countries like ours, where you have severe sarcopenia associated along with severe alcoholic hepatitis, corticosteroids is basically a very, very dangerous tool to use because our patients catch up infections very fast. What kind of options would you suggest to us to use in our category of patients where the MELD score is mostly more than 30 or the DF score is median is around 75?
Yeah, I mean, I agree with you, Sandeep. The lower threshold for starting steroids is well known and to stratify severe alcoholic hepatitis, but I don't think there is ever studied an upper threshold for where the steroids become futile. And I think your question becomes very relevant. We just finished a large international retrospective analysis of about 2,000 patients where the therapeutic window where the maximum benefit of corticosteroids was shown. And I think we started a MELD of 20 where the benefit starts, and we showed that it, I think, ends at about 30, 31. So that's the benefit, the therapeutic window where 20 to 30. Now, specifically your question, what to do with patients who are above 30. So as we all know, currently we have no options. People use pentoxifylline still, N-acetylcysteine in some patients, although the data are very not supportive of use of these two methodologies or options. And that's why the field is ripe for newer therapies. In the absence of pharmacological therapy, I think the best would be to enroll these patients and treat supportively and enroll these patients in the addiction program, depending on what we saw on the algorithm in screening for their alcohol use disorder. And at the last spectrum of this population, as there was some question about ACLF, I think there is some retrospective analysis of ACLF group showing that people who have at least 4 or more organs failed in patients who have severe alcoholic hepatitis, and at day 7, they still have 4 or more organs failed in ICU, are not candidates for steroid therapy. There is very low likelihood that these patients will turn around and you may start talking about or thinking about discussing goals of care. It's not a hopeful answer, but I think as I said that we have to deal with the reality. Some patients, we have to go that route.
With the permission of the chair, can we stop the sessions now?
Thank you, sir. Dhiman, sir.
I think he has left. So thank you, Dr. Sidhu and Dr. Manan, for conducting this session. And
thank you, sir.
Everyone. I'll deliver the vote of thanks just in a few minutes. I just have 2 announcements. The certificates can be downloaded from the same platform, which will remain live till the evening of 6th of December. So those of you who have not taken the certificate can download it from the platform up till day after tomorrow. And the recording of all the sessions, the entire conference would be available on YouTube. We will post the link on our website and also send it to you by email. So I think final closing remarks by our president, Dr. P.N. Rao.
Hello, thank you, Dr. Kaushal. I'm sure, I'm confident that all of you would agree with me that this 27th annual conference of the INASL and this virtual platform has gone on very well, very crisp, without any technical glitches. Of course, the technical part goes to Maisha with the Shefali and the Pranav Biswas. And more importantly, the content, goes to the entire credit goes to Kaushal Madan and the team of all the governing council members. Kaushal Madan has been the backbone, and then as you can see here is the sweetly smiling, dynamic, and soft-spoken, yet very efficient. And all the overseas faculty and our national faculty, they have all done a wonderful job here. And over to you, Dr. Kaushal. It's been an excellent, and congratulations to you.
Thank you all. I just wanted to announce a few awards. So we had initiated a few fellowships last year. One was the JSH, Japanese Society of Hepatology INASL Fellowship, which was awarded to Dr. Rao.
Yeah, Dr. Pathik Parekh, please. Congratulations to you.
Pathik, please put your video on and wave.
Congratulations. I'm sure you come with very good experience from Japan there. Congratulations.
In addition, we had 4 short-term fellowships where young hepatologists could choose going to 4 different centers in the country to learn transplant hepatology, interventional radiology in hepatology, as well as basic science hepatology. So Dr. Rao will announce the awardees.
Yeah, for the molecular and biology and basic sciences in ILBS under Dr. Professor Sareen Kailash M. Kolhe. Please raise your hands. Congratulations. Yes. Right. Raise your hands, please. Put your hands up. So that, yeah, right. And for transplant hepatology with this Dr. Subhash Gupta, Samshir Singh Chauhan.
Thank you, sir.
Congratulations. And transplant hepatology experience in Medanta, Dr. Sunny Bharwani.
Thank you, sir.
Yeah, congratulations. And for interventional radiology with Dr. Akash Shukla, Suprabhat Giri. Yeah. Okay.
So we'll be sending you the certificates for the same. And finally, the announcement for the awards for yesterday's podium presentation award session. Dr. Rao, please.
Yeah, in fact, it's been very, very competing. All the things are very competing and all are good. But then somewhere it has to be one, and then number 2 has to be there. And for this, the first prize goes to Dr. Sandeep Vishwakarma from DCMS Hyderabad for his excellent work on bioartificial functional humanized neobridge therapy as an option for ALF, acute liver failure. And Dr. Sandeep, you are here?
Please,
Right.
please go on. Okay.
Okay. And the second prize goes to Dr. Baibaswata Nayak from Delhi AIMS for the work on microRNA modulating mTOR pathways in hepatocellular carcinoma and in vitro microRNA targeting. Congratulations, Dr. Baibaswata. Are you here? Okay, good. We will convey them their congratulatory messages.
The certificate and the prize money as well. So finally, vote of thanks, and I really want to thank all the speakers and faculty members who have made this conference a success, especially faculty from overseas, mainly because they were in different time zones. Some of them were making their patients wait to be able to participate in this. At some place, for example, Japan, it was almost midnight by the time Dr. Kudo finished his talk. So I'm really grateful to all of them for having participated here. All the GC members, the governing council members who stood by me, guided me and supported me throughout. Our event organizers, Maisha, specifically Shifali, Sharmila, Garima, and Rahul, who really worked hard to over last 3 weeks to make this happen. And obviously our INASL coordinator, Deepak, who definitely coordinated everything and was instrumental in helping us to be able to have this conference. And finally, the IT team led by Ravi Grover and Pranav Viswas, the IT, they provided a wonderful platform. I'm sure the delegates who were on the other side of the platform would have enjoyed the meeting as well as we did here. Their platform, their company is called My Provide. Thank you so much, Pranav and Ravi. And finally, our industry partners, without which this would not have been possible. Naming them, the platinum sponsors, Zydus Bionext, Viatris, it was earlier known as Mylan, they have recently changed their name, and Cipla, our gold sponsors, Sun and Eisai, and our silver sponsors, Abbott, Dr. Reddy's Lab, Hetero, Invig, Lupin Laboratories, and Crizon. So thank you so much. I think it was a wonderful experience, and we have also learned how to do a conference in a virtual format. And I really and sincerely hope that next year we should be able to do this conference in a physical format, if not completely, at least partially.
Kaushal, please let me, as a president of the association, I think I must thank the governing council members by naming them, and the immediate past president, Dr. Rajesh Agarwal, and the president-elect, Dr. Shivaram Singh, and the Pankaj Puri, the treasurer, and the members, Akash Shukla from Mumbai, Dr. Usha Datta from PGI, Dr. Shalimar from Delhi, and Suril Saneja from PGI. All the people, we have had several meetings, and the meetings used to be there at 9:30, 9:45 in the evening. And the core committee and the governing council members, within a very short time, with Dr. Kaushal Madans as the backbone, we have done a wonderful work. Over, please. Good.
3 cheers for Kaushal.
Sir, 3 cheers for all of us.
I think you're really done a great job, Kaushal. Thank you.
Thank you, all of you. Thank you.
Over.
Well done, Kaushal. Excellent.
Thank you, ma'am. Good night.
Good night.
Thank you.
Thank you, sir. We're logging off now.
Oh.